Hello and welcome to the OI Foundation's Clinic Town Hall. My name is Erica Carter and I'm the Chief Program Officer here at the OI Foundation. And on behalf of the OIF, I want to thank all of you for being here today and for the work that you do caring for the OI community. We rely so heavily on our medical professionals and the work that we do here at the Foundation, and meetings like this really give us an opportunity to stay connected with you all. You know, the OIF is not only a resource for families who call us with questions, whether they're looking for a provider in their area or for guidance on a new health issue, but we're also a resource for all of you and to help you connect with other experts and provide you with resources that you can then share with your patients, like our new diagnosis toolkit and our family meetings. And later in this program, you're going to hear from our CEO, Tracy Hart, who's going to talk a little bit more about all of these resources and our upcoming events and educational programs. But please know that we're always eager to hear your feedback, so please reach out to us at any time. And so before we get started, just a quick reminder to please keep your microphones muted throughout the program. If you have a question, you can use the chat feature or the raise hand function, and we'll be sure to get to you. And this meeting is being recorded. We'll share the recording with all of you, so you can go ahead and share those with your colleagues. And on that note, I have the great pleasure in introducing our meeting chair, Dr. Laura Tosi. Dr. Tosi is the director of the Bone Health Program at Children's National Medical Center here in Washington, D.C. She serves on the OIF's Medical Advisory Council and our board of directors, and she's also the lead PI for the OIF's PCORI Award. Dr. Tosi.
Thanks so much, Erica. It's a great opportunity to talk to you all today. I thank you so much for taking time out of your busy day. Many of you know I've delivered OI care now for many years at Children's in Washington, D.C., and it's been a great adventure. Of all the disorders I treat, this one has had one of the biggest improvements in quality of life for my patients, but there's so far to go in the future. One of the things that, as we have worked on our PCORI grant that has come through over and over again, is that we want to be sure that we share what we have, what we know, with all of the clinics that we can possibly touch. There's a wonderful term I can't take credit for called democratization of healthcare. And so we want to be sure that we have shared as many of our advances with you as possible going forward. So let me not take up precious time of the wonderful speakers we have today, but I will make one quick announcement. There'll be a little questionnaire at the end, but oftentimes, you know, we're all so busy, well, we don't fill it out. If you just are bored or want to do something else, would you go into the chat? Would you tell me who you are? Would you tell me what is your area of interest so that we, in future town halls, are addressing everyone concerned? And last time we met at 7 o'clock Eastern Standard Time in the evening. So is that better for you, or is it an afternoon better? Is it better to have a 1 hour or a 3 hour event such as this, where we can really share updates with you in a more extensive way? And finally, what topics do you want to know about? So please, this is your chance to reach out to us in multiple ways, and I hope you will. Now, it gives me great pleasure to introduce our keynote speaker. Mike Bober is Dr. Michael Bober, pardon me, Michael, is a clinical geneticist. And most important, he's director of the skeletal dysplasia program at DuPont. And he spends all of his time on this. And so he brings us great expertise. He was a great help, really leader in helping the OI Foundation provide you and your parents with more information about care for the child with moderate to severe OI in the first year of life. Michael, thank you for being with us.
Thank you. I hope everybody can see that slide. Yes, got a couple nods. All right.
Absolutely.
Dr. Tosi, Tracy, OI Foundation colleagues, I'm so proud to be asked to give this keynote talk and kick off this town hall. I certainly would be listening if I wasn't speaking, and I'm really excited. So hopefully I can stick to my time limit and tell you what I'd like to tell you. And this story for me, taking care of young infants with OI, really started with this young man in a very precise way. And it was the summer of 2013, and his mother rang me up and said, hey, I just had a 20-week ultrasound and the doctors tell me my baby has OI, and they tell me my child is going to die. And I don't know if he's going to die or not, but I want to bring him to you and I want you to do everything that you can to keep him alive. And I was like, whoa, that's a little heavy. But at the same time, that summer, I was dealing, if you will, with my own premature 26-week infant son. So I had an enormous amount of time in the NICU as a father, not just as a provider. And it really made me think about NICU care and how just spectacular the care was that my son received. And I thought, wow, why can't we bring these technologies and why can't we bring this new modalities of thinking that exist in the NICU to bring to bear for these OI kids? And that's really the genesis of my journey. And what you're going to hear is about, 8 years of experience of trying to do this. And what we recognized very early was that we needed to divide up care into different phases, or what we're going to refer to today as stages. So stage 0 is prenatal, everything up until delivery. Stage 1 of care will be from delivery to approximately 2 weeks of age, at which point the children should transition into stage 2, which is the question that we asked of what do we need to do to get them out of the hospital? How can we take this care and convert it to home care? And the third stage is outpatient. Now, I'm going to focus on moderate to severe OI, but you may have mild patients who just sort of jump right to stage 3, or even moderate patients that don't have problems transitioning and don't have these issues. But certainly if any of them do, I think you can use this line of thinking. So OI in its severest forms certainly can be diagnosed from an 18-week anatomy scan. We can see features like skull hypomineralization, fractures and deformities, relatively long fingers, rib beating. And we do know that there are certain ratios that we can use to help predict lethality. One of those ratios is the ratio between the chest circumference and the abdominal circumference, with the potentially lethal being less than 0.6. Well, this particular child, when we finally got ultrasounds done that had this ratio available to us, showed a number of 0.86, which is slightly below the 0.9 normal, but certainly it's not less than 0.6. So why did they call this child a lethal? Well, they called this child a lethal because his femur to abdomen ratio was quite low. But then when you look carefully at the scans, that's what they measured. They measured from one end of the femur to the other without taking into account that the femur actually was deformed, and probably a better measure would have been to measure the length across the deformity. And that gave us great encouragement that this child might do well. So what do we do? And I think this should be the standard. The OI team themselves, either in conjunction with or in addition to the standard maternal fetal medicine NICU group, should sit down with the family and review what is the natural history of OI. Let's take a look specifically at the images and discuss the deformity and the measurements that we see with the family. Let's discuss whether or not there's a molecular confirmation of OI. But also the fact that the molecular confirmation tells us it's OI, but not necessarily what's going to happen. And we want to tell the families and discuss with the families what are long and short-term goals of care for a provider if we were to do everything we could do, but also listen to the family and learn from them about what their goals of care would be for their child. And really, a lot of it comes down to respiratory, but there are also some other things. Now, from a long-term perspective, our goal as clinicians taking care of children with OI is really to be able to raise independent and productive adults, or help the families raise independent, productive adults. We want these folks to be happy, to be self-confident, to have a long and healthy life with the skeleton that they have. And we want the families to recognize that counting fractures is not helpful and actually can impede development. And hopefully at the end of this conversation, which may take multiple circuits, we come to an understanding about goals of care and what are we going to do. But as we're having these conversations, invariably, the family keeps asking the same question. Is it lethal? Is it lethal? And I know Deb Krakow's here. I'd be interested to hear her thoughts on this after we're done. But I would say as a pediatrician, I don't know what's going to happen until you hand me that baby. Ultrasounds are in a lot of ways like Rorschach tests for me, difficult to interpret, but once I have a baby, I have a much better idea. And we talk about these different scenarios. What about intubation? What about CPR? What about comfort care? And I would strongly suggest, and we have this problem occurring repetitively, that hospice and comfort care should not be unilaterally imposed on a family simply because of an ultrasound diagnosis at 18 to 20 weeks. I cannot tell you how many calls we get a year from a family that says, my child is now 3 months old and nobody will take care of them because they're in hospice and they just don't die and we don't know what to do. So hospice and comfort care may be absolutely appropriate for some families, but it should not be imposed on those families. So now we got to get the baby into our NICU. And I mentioned Deb already. She was part of this group, as were many other centers in the BBDC. And essentially with this, what we learned from this study is that the mechanism, the mode of delivery is fracture neutral. Doesn't matter whether you're born by C-section or you're born vaginally, the same number of fractures are likely to be there. So therefore, which mode of delivery should be used really needs to be based upon maternal and other fetal factors. Is the child breech? How mineralized is the skull? What does the mother's pelvic outlet look like? All of those sorts of things. And this is where the team comes in. I'm presenting this, but believe me, there's a lot of work that I did not do that went into this talk. Our NICU team, our therapists, our orthopedists, and I could go on, and I'm sure I'm going to leave somebody out. But there's a lot of preparation that goes into this. We need to make sure we have all the equipment, extra equipment, specialized equipment in the delivery room. Egg crates, extra blankets, perhaps a laryngoscope for fiber optic intubation, positioning aids for intubation. We want to know exactly what's going to happen. Think of this as a Broadway play that you want to be choreographed. When that OB takes the baby from mom, the path to that isolette needs to be choreographed. Who's going to handle the baby? Who's going to do what? That should be very well mapped out. The person actually doing the resuscitation needs to be thinking about OI. And you know, you're going to follow the standard neonatal resuscitation protocols, but how much do you hyperextend the neck? How hard do you put the face mask on? Here's a box where it says, does the child require chest compressions? Well, maybe it's more prudent to try and give epinephrine first rather than trying chest compressions first. And all of these things should be worked out by that resuscitation team. So as I was, like I said, challenged to think about how I would handle this, and it occurred to me that these children in that moment of being delivered are getting beat up, you know, whether it's fractures from a C-section or fractures from a vaginal birth. There is no escaping the fact that these children in that moment are not only transitioning their environments, but they are having multiple fractures. So when we get that child into the delivery room, we need to be thinking about almost as if this was a child who came out of a car accident. We need to manage their pain. We need to manage their airway. We need to manage their respirations. We should not be treating them as a typical newborn. The other factor that comes into play is chest wall compliance, is these bones are soft. And when a child with severe OI inhales, rather than the ribs creating a thoracic volume that is stable, that thoracic volume decreases and diminishes as the diaphragm pulls down. And we need to think about that and manage that as well. And it's a transition. So this is our thoughts about what should be happening into these first 7 to 10 days. It's going to take 7 to 10 days for these fractures to get a callus on them. And we need to be focused that this stage of care is different, I believe, than the other ones. So I have never been part of the delivery room team. I don't think my hands are going to do anything but complicate that well choreographed dance, but I am usually standing in the NICU waiting for the baby to arrive. And the first thing we're going to do is we're going to meet our patient. And what are we going to do? Well, if this is an example of a child that we're going to see, what does that look like? I mean, if you're not focused, the first thing you're going to do is your eyes are going to go to that child's legs. And you know what? That child's legs are the least important thing there is. We want to watch that chest wall. We want to understand how this child is breathing. We want to know vital signs. I would say to you, that's a nice pink child. I probably don't have to worry too much about the blood pressure. But if I needed a blood pressure, I would absolutely get one. Are they moving everything? Immediately, we need a weight. I've already told you, or perhaps, that the delivery room, the baby, once it's put in the isolette, should be on an egg crate. Well, it's not hard to have that egg crate weighed prior to going to the delivery room. Now we don't have to pick up the baby to put him on the scale. We pick up the egg crate and the baby, and we have the scale zeroed, so we know what the weight is. We know in these severe infants, we're going to need lines. So let's get our UAC and our UVC in. We're going to need to give medicines. We're going to need to draw labs. We need to stabilize them. Usually this is oxygen or maybe a little bit of nasal CPAP. And we need a chest x-ray. I do not need an x-ray of that leg. I don't need 12 x-rays of all the extremities at this juncture. At this juncture, it's really all about respiration. So we are going to employ a strategy that the NICUs use all the time, but not for term babies. They use it for the micro preemies like my son. They're going to cluster care and they're going to leave these kids alone for 6 or 8 hours at a time. And that's what we want to do. We want to give them the respiratory support they need. Usually this is PEEP, sometimes significant PEEPs, well beyond the normal 4, 5, 6 that you might see in a term infant. We may need 10 or 12. We want to minimize the chest wall movement. We want the abdomen and the chest wall to move together rather than abdominal breathing. We know these children have just had multiple fractures. We need to manage their pain, and there is no reason to screw around with Tylenol at this point. This is a child who's going to need a continuous morphine drip. Let's start it. Let's take away guarding and splinting. Let's make this breathing as comfortable as possible. And we just, again, want to cluster care and minimize things. And this is an example of a baby that was born at our center. She was breech. She had one leg came out that was up like that. And here you could see the x-ray that we took when she was born. We did not focus. You can zoom in and magnify and count fractures, but we knew they were there. We were focused on making sure that we had air inflation in the lungs, trying to understand what our rib cage looked like and go from there. Obviously, we need to feed these babies. We need good nutritional support. And with a compliant chest wall, there's a significant complication of abdominal competition. So if I fill that child's belly up too much, that diaphragm is not going to be able to pull down, our tidal volumes are going to be decreased, and our gas exchange is not going to go well. What we've learned over the years is that 5 to 10 grams a day is probably the best expected weight gain for these most severe infants. It's not 20 to 30. And overfeeding these kids can lead to a lot of respiratory issues, potential aspiration, throwing up. And we want to make sure that they give all the micronutrients, all the macronutrients, all the calcium that they need to grow their skeleton and develop their skeleton and heal their fractures, but not overfed. We need to find that balance, and most of the time, vitamin D is supplemented. This is another critical piece, is for the last 20 weeks, this family has been on a razor edge about whether or not this child is going to survive or not. And we need to do everything that we can to encourage bonding between the child and the family. At the same time, in this first stage, we want to minimize handling. And this is a little bit tricky, but we want the kids to be handled on the crates for about the first week or so. And if it hadn't been done previously, we want to confirm that the diagnosis is OI, but I would emphasize that the molecular confirmation is not necessary in order for us to initiate treatment. The only other thing to mention is a head ultrasound. A lot of these babies have craniotabes. They may have had a small bleed during delivery. Hydrocephalus can be part of the picture in some of our more severe infants, and at the very least, we'd like to have a baseline. So that is something also to do during this stage. So I mentioned this, the chest wall compliance and respiratory insufficiency, which may be exacerbated by rib fractures and splinting due to pain. We often see respiratory rates being elevated even when the children are doing well, and I think that's a product of minute ventilation, which is the combination of tidal volumes times the respiratory rate. So essentially these children are taking smaller, more frequent breaths, and that should not necessarily be considered abnormal. yes, pulmonary hyperplasia can happen, and there may be children whose chests are so small, especially if we do get down to that 0.5, 0.6 ratio, that there is not enough lung tissue to support respiration. But at this juncture, really, if we can get normal oxygenation and normal carbon dioxide levels, pulmonary hyperplasia is not what's going on here. It's the chest wall that we need to take care of. So what do we do? Well, it depends what we see. If it's a little bit of hypoxemia without hypercarbia, we're going to use a nasal cannula, just deliver a little bit of oxygen. If there's more respiratory distress, increased work of breathing, more hypercarbia, then this is where the PEEP comes in, whether it by high flow nasal cannula or CPAP, we want to deliver that. And if that's not enough and the family is on board with the care plan, then we will intubate. We're trying to stabilize that chest wall, get the children comfortable. And again, this is the first week. We want to get them to heal their fractures, and we need to manage their pain. At the same time, we want to make sure that we minimize damage. So we don't want to be using Lasix or other calcium wasting diuretics. In terms of overall care, minimizing blood pressure, you can use the UAC if there's hemodynamic instability. We want to minimize heel sticks and lab draws. Again, as much as we can, just let the child be. We have some lines that we can draw from. Really important, pincer grasp. We just never want to do anything with an OI baby with pincer grasp. We want to use our palms. Sedation and analgesia during IV placement allows for a less traumatic procedure. We can monitor CO2 once correlated with the TCOM, so a sticker on the chest. Whoops. And if we do need to intubate, we really want to use sedation, paralysis even. The easier it is to intubate for the provider, the easier it is for the patient. We get calls oftentimes from centers who are a little reluctant to intubate children with OI because they're afraid of an upper cervical fracture. All I can say is we've never seen that happen. I'm sure that it's a real hypothetical, but practically haven't seen it. And there are ways, including with video scopes, to do this safely. If a stranger walks into the room and mom and dad aren't there or our nurse isn't there, we want to have our fragile bone sign up. Again, we're trying to cluster care. We do not want to lift the legs for a diaper change. We want to lift the lower back and the butt. We want to use our palms, and if possible, to care people. Onesies, we do not want them going over heads. We want them to be, the babies to be set down into the onesie and then it buttoned or zipped or Velcroed over their chest. Weights a couple times a week is enough, it's adequate. And if possible, we'd like the same nurses to be caring for these children day in and day out, because that helps with continuity and helps understand what the child needs. And here you can see in that first week how we would prefer the children be handled here. This is hard to tell. This is mom's lap and her child is on a pillow there. That first slide, when I met my child, I told you we looked at that leg and we said, don't worry about the leg. This was an example of one child who had one leg in that position, and our therapists were able to build these little teeny square, I guess, cubes that supported the leg, and gently over the course of a week, this leg fell all down by itself without the need for any other interventions. at least in our NICU, we have a wonderful physical therapist who totally gets it and helps with the positioning, with the egg crates, with the blocks, with helping transition from bed to lap and everything that we need. But if we see the signs that the child is having some pain or difficulty during this session, it's okay to use an extra dose. We do want to make sure that we don't get pressure and injuries from not moving the child. And if appropriate, and the child is doing well enough, tummy time is absolutely fine. So now we've got through the first week, 10 days. We have callus on all our fractures. We have an idea about what type of respiratory support the child is on. Hopefully we've turned the corner from weight loss to weight gain. And now we need to look up and we need to say to ourselves, okay, what do we need to do now to be able to facilitate this child transitioning to home? Well, respiratorily, if we're on a small amount of CPAP, we know that that's all. We don't have to go anywhere. They can go home on home CPAP now. And that's certainly a technology that is new. It was used for my son. It was not around when Dr. Salence and the others were discussing these type 2 lethal kids. We have technologies and tools that did not exist in the 70s. And I would make a strong argument that some of those problems, not all, but some of these children absolutely have better prognosis than what was in 1970. Some of the children may need significant respiratory support, and we would think, well, this might be a child who's going to need a tracheostomy. Interestingly, in our experience, the children who really seem to follow this track are the premature infants. It's not the infants with the worst OI, it's the infants that were born at 30 weeks or 32 weeks, rather than getting later into term. We want to continue our 5 to 10 grams a day of growth strategy. Now that our calluses are there, we want to begin the morphine and opioid wean. We'd like these children off of pain medicines, if possible, or at least around the clock pain medicines, and use Tylenol and opioids as needed. Here's another example of some adaptive padding that went into putting a child with OI into a more typical NICU rocker there. We want to now start to get the kids off of the pillows, let the families get comfortable with picking their baby up. I'm a really big believer in protecting the spine, and I don't want to have the child's shoulder directly over the pelvis so that gravity is moving through those anterior vertebral bodies. And I'll get back to this in a little bit, what I mean by this, but I want to avoid soft-backed hammock-like devices. Now that the child is doing a little better, it's very reasonable to get those hip ultrasound and take a look. We may want to follow up ultrasound again of the head, and we need to check our hearing. And it's important to understand that as I walk through this process is slow, and it's kind of what I describe for the most severe kids. But you may have a moderate child basically jump out or be delivered and go right into stage 2. They may come out screaming and pink and moving all their extremities and taking a bottle, and none of these other interventions are necessary. And in the same way that when we get to stage 3 in the outpatient side, this may be very similar to a mild child just going right home. So what happens if we have a new fracture? Well, usually that shows up as changes in heart rate, things that look like pain and discomfort, and the lack of movement in an extremity. And classically, we just do a little soft splinting or wrapping. This is mostly to allow care providers to know to stay away from that limb. And once the child starts to move that limb, then we take the cast padding off. And that can just sometimes be 3 days. Comprehensive discharge planning. We really want to set patients and their families up to succeed. We don't want them running back to emergency rooms or urgent cares, especially when they're remote from us and their care teams have no experience. Handling a child to get an X-ray of a leg that they're not moving, that we wouldn't even intervene on besides cast padding, can cause a lot more trouble. So that needs to be discussed. Our NICU case managers are critical in getting everything set up. We need to, if the child is NG or G-tube fed, that teaching needs to be done. We'd like to watch the family, take care of the baby in the hospital full time, make sure that they have what they need in terms of skills. We want to talk to their PCP. We need to figure out a plan for feeding and weights, who's going to do that. Oftentimes what we have the families do is to get a medical grade scale. I need 2 decimal places, and once a week they email us a weight that we can then use to adjust the nutrition. And of course, the official discharge photo is the last step of phase 2 or stage 2. And I don't know if you can read this that well on the screen, but it says here, I picked my own due date, check. Made a dramatic entrance, check. Rocked the NICU like a boss, check. And peace out, NICU. So some of the families, it's a big deal to go home. So now we're home. Well, if you have a moderate child who, again, might have jumped right to stage 3, I think we need to be careful. And I would still strongly recommend a sleep study in these kids. We want to make sure that they're not hypoventilating while they're asleep. For the more severe patients, again, they're going to be on the high flow nasal cannula or CPAP. We can use those technologies at home now. They certainly didn't exist in the 70s and 80s. Most of our severe kids need this. And they need PEEPs of 10 to 12 to adequately expand the chest wall and exchange gas. And our experience is that this need can persist for months. And if there's on a little oxygen, that's the first to wean, and then we wean the pressures. And then as the infants begin to cluster their sleep, we often can remove the interventions while they're awake and only use them during sleep. But some cannot exchange gas or cannot use the home CPAPs to adequately ventilate, and they need to go to a tracheostomy. And this is one such example. I talked to this family actually this morning to be able to use these pictures, and I did not know this, but they were happy to report that in 2 weeks she's going to be decannulated right at her 6th birthday. And here you can see she was a 32-week premature infant. Here she did fine on CPAP, but we could not get the CPAP to home settings. And ultimately a tracheostomy was placed. She lost the need for her circuit while she was awake. And here she is just a couple days ago, I've been told, little Miss Sass, who will be decannulated in 2 weeks. And I think in this particular situation, this was not a chest wall problem. This was a tracheomalacia problem related to prematurity. Nutrition, we still, in these most severe kids, are going to stick to our 5 to 10 grams per day goal. Here's an example of what the families typically do with us is they take a picture on the scale and we see the weight and we see the child, and we can make our determinations about what to do in terms of adjusting the feed. It's really impossible when somebody has a lot of CPAP getting blown into their nose and mouth for them to feed. So the NG feeds and the G-tube feeds are really necessary when significant respiratory interventions are going on. And as these wane, we start to feed more by mouth. And as we get home, again, it's really important to set goals. We leave the NICU, and a lot of times the families are just so focused on, I don't want my child to have another fracture. I don't want my child to have another fracture. And then they minimize the contact of the child with their peers or their siblings or their environment. And they don't let their child do as much as they could. And this is really an incorrect strategy. We want to set them right. We want them moving. Physical therapy is important, whether it's aqua therapy or land-based therapy. We want to encourage movement. And at the same time, we really want to try and protect their spines. And for me, this is recommending achondroplasia-like recommendations. So there is no unsupported sitting. There's no bumbo chairs. There's no soft backs like an infant wrap or carrier or a bouncy seat that doesn't have back support. I don't want the hammock. I want to try and protect those vertebral bodies and not have crush fractures develop until the children are ready to start to get more vertical. Fracture management, we try Dr. Franzone, Dr. Cruz, the orthopedic team, to supply the families with home splinting kits. We try and avoid the ERs. These days, you can see Dr. Franzone here doing a little bit of some Zoom splinting with mom and a young lady with an arm fracture. This is an infant with moderate OI who went right home but was back at 3 weeks of age with a significant femur fracture. And lastly, the last topic here, I have a couple minutes, is pomidronate. I'm a pomidronate guy. I'm not a Zometa guy. That's beyond the scope of this talk, but we want to give our first cycle as early as possible as we balance it with the patient's clinical status. They need to be stable from a respiratory and nutrition perspective. Ideally, we can give our first small dose on day 8, 9, and 10 at the end of that first stage through the UVC. They need to come out by day 10, and the idea is we give it at day 10 and then we can pull out the UVC. This also matches with our pain management strategy because we know that bisphosphonates do have some pain diminishing properties. We'd like to begin with the classic reduced dose to try and minimize hypocalcemia, which we see these need to be monitored, not so much in the middle of the infusion, but remember your hypocalcemic nadir is going to be 48 to 72 hours later. And so it's 2 to 3 days after the infusion that we need to make sure that we're not getting hypocalcemic. Potentially, there is a flu-like reaction that can occur and exacerbate respiratory status. And once we have that in, my thought is, especially for these most severe kids, is look, I just gave a half of a cycle with this reduced dose. Why do I need to wait 8 weeks? We'll sometimes, depending upon the clinical status and the severity of the OI, give our first full cycle somewhere between a 4 and 8 week period. And then we essentially stick to the New England Journal, Dr. Glorio's dosing from that point on. This book got mentioned. It's an excellent resource that we certainly helped contribute to, but a lot of people had their hand in this. I think it's an excellent resource for families to help them navigate this process, and would encourage you to refer them to OIF for more information. That being said, this is our OI team in our OI shirts. It's a big team, and it takes a big team to execute this kind of care. This is not me walking into a NICU or This is an amazing group of orthopedists, really talented NICU people, Dr. Costa, Dernberger, Katie Preedy. We have our neurosurgeons, our PTs, including Scott, who I mentioned several times, our social worker. Deep breath. And just to conclude, for those of you who wondered what happened to my 26-weeker, here you see his picture. Happy ending too. So I think we can do a lot better taking care of children with moderate and severe OI, especially getting them through those first couple of weeks of life, if we just tweak our strategies a little bit. So thank you.
Michael, that was awe-inspiring. The most thorough, complete discussion I've ever heard. And I've been doing this for a long time, and boy, did I learn a lot. Sandy Sandhouse has already sent a note to you. Fabulous. I'm so pleased that we're recording this, and I hope everyone on the line will share it. I am going to try very hard to keep us on time, but perhaps if you do have a question, put it in the chat line, chat box for Dr. Bober. But
thank you. And
that was so comprehensive.
Thank you, Laura. I appreciate that. And let me just say that I will be staying at the end at that 4 o'clock sort of happy hour thing, and I'm happy to talk about this questions and stuff at that point too.
Wonderful, wonderful, wonderful. I'm so glad to see the accolades coming up on the chat box. Now, you know, this has been a wonderful but crazy year for all of us, and a terrible year at the same time. And to give some perspective to that, I now would like to introduce Kara Ayers, PhD, who Kara is Associate Director of the University of Cincinnati University Centers of Excellence on Developmental Disabilities, and Director of their Center for Dignity in Healthcare for People with Disabilities. Kara has OI herself and has been an extraordinary resource to the community throughout the COVID pandemic. And it gives me great pleasure to introduce her today. Kara.
Thank you so much, Dr. Tosi. And yeah, just echoing what others have said, Dr. Bober, that was really empowering, and I think set us off on a great path for, hopefully we're pretty high, and I'll try not to bring us pretty low as we talk about COVID. Erica, can you see my slides okay? Yep, okay, great. So I'm going to be talking about no body is expendable, how the OI community has faced COVID-19, and both kind of recapping where we've been and also giving some specific recommendations about where we'll go from here. I don't have anything important to disclaim or disclose today. I don't have any conflicts of interest, but I'm very passionate personally and professionally about this work. Dr. Tosi shared a definitely long enough introduction. I just want to highlight that each of you have a USED in your state. So I happen to be the Associate Director of our Cincinnati USED, but you have at least one USED in your state. And I'm often reminding people that OI qualifies as a developmental disability. So that may be an important resource for you, whether you're a professional or an individual community member. And also, most of the work that I share today will be related to my work as director for the Center for Dignity in Healthcare for People with Disabilities. And we focus in on inequities of healthcare. And what we mean by that are preventable, avoidable outcomes, poorer outcomes faced by people with disabilities that are influenced by ableism. So by that devaluing of the disabled life. And that was really what I found so empowering about Dr. Bober's discussion about the valuing of life right from that prenatal period related to OI. So I'm trained as a psychologist, and we like to use metaphors to challenge you to think differently and think deeper. And one of the metaphors you may have heard about COVID has been that we're all weathering the same storm, but we're in different ships. And I think that we could think of these different ships related to our bodies and maybe even related to the severity of OI. But I also think it's important to recognize that our ships are different because of medical systems in general. And we saw that from the very start of the pandemic, unfortunately, in ideas about who would be likely to survive and therefore who should and should not get care. And so it has been very anxious time for people with OI and remains such. I was very excited that Dr. Tosi allowed me to give you a quick preview of some OI specific information that her survey gathered about what we've learned about people with OI and COVID. And I thought I would help frame that a little bit in what I've done with larger work, more cross disability. So in the survey, about 14% of the respondents with OI reported that they have had COVID. And interestingly, about 43% self-diagnosed, which I found interesting, but in looking at other literature, looks to be about in line with other populations that self-diagnose. And this survey was of 649 respondents. So a great turnout for our community, but also plagued with similar challenges that we often have in terms of higher response rates from women and from white individuals. So always working to get a wider representation of our community. And again, from Dr. Tosi's work, these long COVID symptoms, and they're outlined here from her findings, things like coughing, fatigue, joint pain, and about 50% reported at least one of these symptoms lasting longer than 4 weeks. And what I find concerning about this is just the overlap of several symptoms that are already difficult or difficult to differentiate for people with OI. So whether they may be exacerbated from what was a baseline for a person or new for them. So what I would challenge us to really put on our to-do list as we go forth through these next stages of hopefully pandemic recovery is working with rehab professionals as that field in itself grapples how to handle and treat long COVID. It'll be critical for there to also be feedback from those familiar with people with OI and again, what our baselines were before and getting back to that. So some enlightening news has been that while at the time of this survey collection, 34% had received the COVID vaccine, which across general populations is a good sign, a positive sign. And also, I think even more positive news is relatively low hesitancy rates. So, and I always clarify to people that we don't want to confuse hesitancy for lack of access, and that could be access to vaccination itself or access to information about vaccination. And people with OI who have raised concerns and had questions have raised some really valid considerations. So things like worries about dosage. We've seen people posting in several of the social media forums about, you know, I'm an adult, but I weigh 65 pounds. Are you sure that it's safe for me to get this vaccine? And so several of us that have kind of tried to cross-pollinate public health messaging have shared that, you know, this vaccine is not weight-based. So from everything we know, it would still be safe and outweigh the risks of COVID itself. But there are valid points in raising that, you know, people with OI are largely excluded from many clinical trials. So I think, again, adding to your long to-do list related to advocacy is some more innovative methods rather than just blanket exclusions, so that I hope to see in a few years that we're able to give people more confidence to say, you know, there were actually people with either similar collagen disorders or, you know, a grouping of collagen disorders. As it stands right now, we honestly can't say that clinical trials are always representative of our populations. Another thing that is concerning is the low vaccination rates among direct support professionals. Many people with OI require sometimes multiple people in and out of their homes to provide for daily care. And we're seeing very low rates of vaccine acceptance among those groups. So I am concerned that in different states, we're tracking more outbreaks among group homes, which individuals with OI are living in. And then again, we're just likely to see this pattern continue if we can't get that group more vaccinated. And again, people with OI, like others in our communities, have sometimes fallen to the disinformation campaigns. And, you know, while there's not hard data on this, you could make the case that we may be even more vulnerable to that when we have cases of isolation and, you know, in limited social circles to kind of compare those sources of information. So, and adding to your to-do list as hopefully an advocate as well as a community member and a professional, just reminding you of the long-standing but now magnified problem of disability data. You know, it's been frustrating to watch that we've missed so many opportunities in data collection even during this pandemic, and also with the vaccine, even in a, so one that comes to mind was the COVID pulse survey with CDC, but also even the V-check that follows up on the safety of the vaccine. That would have been such an easy opportunity to gather that data there so that we could have more confidence of how people with different disabilities, including OI, are responding to the vaccine. Even death certificates are not standardized in their data reporting, so we likely have an underreporting, not an overreporting of deaths in our disability groups. So again, it's unfortunate that we're not accurately able to give how many in our community have been lost, but it's been significant. And the other point I'd make about disability data is it almost felt as though we were in this cyclical punishing cycle related to our problem, because the CDC would say, well, show us the data that groups are more at risk. And groups like the Down syndrome community were able to give that data because they have very well-funded, ongoing NIH supported programs that were also agile and able to show that. And actually, my advocacy stance would not be to advocate for the OI community to be able to provide that. One, because it's likely not realistic, but two, because from a public health stance, I didn't find it helpful to have just a growing list of diagnoses of those that were able to advocate. What I advocated for, along with my colleagues, was to have broader categories, again, like the category of developmental disability, and having better clarity that we do actually fit in that. And there's some other categories that I know our community has talked about that we may fit in, like chronic lung disease and some others. But so again, my message wouldn't be to get OI added in those priority groups that you saw floating around the states, but to have broader groups so that there would be better clarity of where we fit. And that's a more equitable strategy. We also have a policy problem. So this session today is titled "No Body is Expendable," related to a publication that some colleagues and I wrote early on in the pandemic about some medical ableism that we saw in the early months. So we saw crisis care standards released that rationed care away from people with disabilities should a hospital surge or should ventilator shortages become an issue. And many of those standards invoked language that definitely could have rationed care away from people with OI. Some states included language like if someone needed assistance with daily living, people with lung difficulties was another, people with difficulty walking was even one of the state standards. So a few weeks after those standards were released, the Department of Justice stepped in and ruled that these standards were discrimination on the basis of disability. And so states, they edited revised their standards, and those same wordings do not stand today, but rationing of care is still very much a threat. As an adult who's been hospitalized, I know that I've let everyone know in my circles that I do not feel safe being in a hospital alone without a caregiver. I have seen how my life has been kind of devalued. I mean, we look our worst then. And so I need an advocate with me. And that has been another policy problem, in that the visitor bans that were put in place related to COVID infection were misinterpreted that support people were the same as visitors. And so that, again, by the Department of Justice has been reversed and clarified that a support person helping you advocate or helping you transfer, whatever it may be, is not the same as a visitor, and it must be allowed. But that is not actually the same as, that's not actually trickling down to the ground of the hospitals as we would like to see it. In the interest of time, I'm actually going to skip this part, but I'll share in the chat box afterwards a link to my whole presentation so you could watch it later. This part was building, if you were able to take part in yesterday's, about the concerning nature of physicians' perceptions on quality of life. And again, I've seen this in experiences with my own hospitalization, where my doctors in emergency settings have been shocked that I work, or shocked that I have a husband or a child, and just kind of doubtful. And so this study that was just released in February confirmed some of those concerns, in that 82% of physicians reported that they believed people with significant disabilities have worse quality of life. And people with disabilities themselves don't actually rate their quality of life in this way. And so other really concerning findings were that only 40% of physicians were very confident about their ability to provide the same quality of care to patients with disabilities. So I just wanted to, reiterate here that we're so fortunate to be among people that know the value of life with OI and the quality of life with OI, but that's not the case. And so that's not the case universally. And I really want to make it a call to action to those of you that do have friends and colleagues in healthcare to use those moments in the break room and at professional conferences to go beyond case studies of OI, but infusing those messages of the value of our life and the potential, because it's clear that we need to have more understanding of that across broader fields. And last on your to-do list is just the challenge that we have an equity problem. Even when we looked at vaccine plans that discussed equity, which means, meeting people's needs where they are, we saw that disability was only mentioned in just a handful of states' equity plans. So that led us in a collaboration with Johns Hopkins, and this is again linked up on my slides, so you'll have access to it, but to look at state by state how these states prioritize disability, define disability. And then most recently, we've been looking at the accessibility of these websites. So you can look at where your state ranks related to that as well. And we're expanding that. We don't want to start from square one with pediatric distribution. That would be such a loss because we've learned so much. One thing that I wanted to highlight on best practices that we've learned from this process has really been that self-attestation was great. I was so glad that people were not forced in most cases to get a letter, but I also heard from providers that said, well, we want to be part of this, especially if their states didn't prioritize people for OI examples, people with OI, for example. So we're trying to pass that on to pediatric distribution. And last, just in closing, people with OI, we need representation on advisory committees, especially ethics committees. I know you have enough to add to your plate, but if your hospital has a chance to contribute to those, it would be so important. And we need to live in the community. We saw how deadly that nursing home and congregate care settings were during this pandemic, and people with OI are in those settings, unfortunately, in some cases. You're not alone in your work with this. So if you need help related to how COVID has impacted things like employment, housing, transportation, or the flip side, transportation barriers to getting a vaccine, there are a number of opportunities that advocates can help you with that. And I just wanted to really close that I remain an optimist. And I think if I made it through the last year as that, then that's a good sign. And I think that we can use this opportunity to work towards health equity for people with OI in a way that extends past COVID-19. So just encouraging us to remember to celebrate our time together, like today, where we focus on OI and realizing that we need to diffuse and distribute that kind of valuing of life further into our healthcare spectrum. And I'm always available, happy to connect whichever way you prefer. My email is here. And again, I'll drop the link to my slides in the chat box as well. I think I got through it. Thank you so much.
Cara, that was wonderful. And I thought I knew about everything you do. And I was so wrong. Boy, you have taken my breath away. And congratulations on the extraordinary steps that you have achieved in a really very short period of time. Unbelievable. Thank you. Great talk. Now we're going to move on to a completely different topic. Eric Rush is joining us. Eric will be speaking on designing individualized infusion programs. I think one of the things that's absolutely true in OI is if you go to a different city, you'll find a different infusion program. And so that can be pretty confusing. Eric is a terrific individual. He's a clinical geneticist. As you can see, he's an endowed professor, and he works at Children's Mercy, Kansas City. Eric, thanks so much for making time for us today.
Thank you, Laura. I really appreciate being here. I have the unenviable task of following two incredible talks, but I will endeavor to do my very best here. I assume, can everyone see my slides okay? Perfect. Okay, great. Mike's nodding his head. Thank you very much. So what I'm going to talk about today is designing individualized infusion protocols for people with OI. And some of this is going to require a little bit of kind of evidence basis, but and a lot of it's going to be my approach to bisphosphonate treatment in children and adolescents with OI. as well as a little bit about adults with OI. As a med-peds geneticist, I kind of try to treat a little bit of everybody. But I think this talk, maybe more than most, is important to put some caveats in place. I do try to make a lot of what I'm saying informed by the evidence, but do keep in mind that a lot of this presentation is really opinion. And I try to offer it in that spirit, in the spirit of kind of equanimity, but also because I want to actively encourage spirited discussion. I think that there's probably some people that do it slightly different ways, and I think that's okay. I certainly don't have the corner on all the wisdom here. And the other thing I would say is, even though bisphosphonate therapy, it takes a lot of our discussion, it's really only one aspect of the multidisciplinary care of patients with OI. I think we can all agree that multidisciplinary, patient-focused care for OI is of benefit, regardless of kind of our individual opinions about bisphosphonate therapy. And I'm also not going to discuss other agents just because I really don't have time. But I want to start kind of with framing a little bit just about the history of bisphosphonate use in OI. As far as I can tell, the first use of bisphosphonates in OI was published in 1987. And this was, I believe it was in the Swiss literature, but it's been a while. And then we all are aware of this very important study that was led by our colleague, Dr. Glorieux, and other colleagues in 1998, where a number of patients with severe OI were treated with pimidronate and experienced an increase in bone mineral density, an increase in metacarpal width, and a decrease in fractures. Well, this is very interesting, and a lot of studies of various types have followed this. And what I take away from these studies is kind of the following general themes: is that we do tend to see increased density, we do tend to see fewer fractures, reduced bone pain, and improved functional status in our children and adolescents with OI. Those are my observations. But I acknowledge that some of these observations are limited by the quality of the data, because a lot of these are observational studies, not randomized control trials. I think I would have some ethical concerns about an RCT at this point in children. And so there's a little limited. Adults, even more limited. I think the smaller adult studies do suggest that we can increase the bone density, but I think it's pretty inconclusive what we're able to do with fractures or functional status or pain in our adults with OI. And so I have, over the last few years, have really kind of dialed back the promises I make to adult patients about how they're likely to respond to bisphosphonate therapy. And some of the same limitations are present in terms of observational studies, and what's been done in terms of controlled trials have been relatively small and relatively heterogeneous. And this kind of culminated a few years ago in a Cochrane review that was looking at 14 clinical trials with about 800 patients that were included in the analysis. And the conclusions they drew were basically that, yes, we can increase bone mineral density in children and adults in OI. What they did state, that was at the time a little controversial, was that it's unclear whether these treatments actually consistently decrease fractures. Some studies do report this independently. They didn't say that they don't work. They just said that the quality of data was not enough that they could independently verify this. And so they did not conclude that there was improvement in pain, growth, and functional mobility. Again, this is in many ways counter to some of my experience as a clinician in working with patients with OI, but I feel that it's important for us to at least approach the data on the level. And they didn't provide an opinion on the pimidronate versus zoledronate, which is kind of the eternal question for many of us. So how do I approach patients? And so when I approach the pediatric patients, I think about this in different phases of therapy. And one of the first phases is, when do we start therapy? And I look at fracture burden when I decide to start therapy. I look at their experience of pain, discomfort, and any functional limitations. And I do look a little bit at bone density. It's not the most important thing that I look at, but I do look at it. And so which therapy do we start? I still like pimidronate in younger kids. Again, I think our friends in different centers use different preparations, and that's certainly fine. But my experience has been that I think especially the younger kids maybe get a little more relief from pain. I don't have data to prove that, but that's been my clinical experience. And I like the idea of doing more frequent infusions in the rapidly growing bone. For the older kids, I do like zoledronate. I don't perceive as much of the difference between the two of them in older kids. I like the convenience. I like the infusion length and intervals in the older kids. And for just in terms of approaching the starting dose, I tend to start the patients with type 4 and type 1 OI on a lower dose protocol. I tend to start people on with more involved disease on a higher dose protocol. For zoledronate, I kind of do the same thing. In all honesty, with the zoledronate dose, I pretty much take the really great zoledronate protocol that Frank Rausch created for use at Shriners in Montreal. Again, there are other protocols out there. I just happen to like that one, and so that's kind of how I make decisions on what dose do you start with therapy. And again, I think this is one of the places to really interject and say, this is just my clinical observation. I mean, again, that we don't really have a whole lot in the way of dose finding data for us to be able to support this. This is just this is a system that I've developed internally that I think is working for me. And then how do you adjust that dose? Number one is, how do you adjust those doses for what we would consider to be an insufficient response to therapy? How do you change it if you don't think they're doing very well? If their fractures have not reduced the way you want them to, if you think they're still having a lot of chronic bone pain, if you think that their bone density has not really responded the way you want it to, those would be reasons to at least consider a dosage adjustment. Sometimes we'll get bisphosphonate dropout. Sometimes you'll get a lot more pain, a lot more discomfort, a lot more fatigue, kind of really leading up to the infusion. I see that a lot in patients. Sometimes you can change those intervals without changing the total annual dose. So you can go from every 16 week to an every 12 week or something like that, and you can still keep the same annual dose. I've actually found in some cases that's been helpful to do that. If you have an excess increase in bone mineral density, if you're worried about hyperdensity, again, I feel like if you're paying attention to your patients and you're following them frequently, hyperdensity is not something that really ought to sneak up on you. Typically we have several years in advance for patients that have a really brisk response, and you have the opportunity to dial back if you need to. So so I think you have to pay attention to those things. But I can't say that that's generally been a huge problem if you're able to anticipate those. And then how do you transition to a maintenance dose? If you have a patient who starts on higher dose therapy, and then you have a good response and you want to dial them back to a more maintenance therapy, do you do that all at once, or do you titrate down over a couple of years? I tend to do the latter. Because I find that it's a little less jarring for patients, but some people do it a different way and have had very good success that way. So again, there's more than one way to do this. And then how do you take them off therapy? Well, again, we don't really know exactly what the right age to discontinue therapy, but I've always felt that for patients who are pediatrics that are still growing, I feel like it's a good idea to treat them until they're skeletally mature. I usually wait for that skeletal maturity. Sometimes if they're really involved, or if we've had a slow accumulation of bone density, I may give them a year or two after skeletal maturity with a reduced dose, and then we'll help them taper off therapy. But at the end of the day, I like giving those young adults as they're done growing. I like giving them time off of infusions, and especially if they're heading off to college or heading off to the workforce, it's nice to send them off to those experiences without having to worry about infusions. We don't always get there, but that's one of my goals for our young people as they conclude therapy. And then changing gears a little bit to finish up, what about the adults? It's a little bit different. Our thought process is different. We can decide to use some of the same findings here. Fracture burden is usually not as big of a deal. Our adults just don't break as much. I mean, again, I know that there are adults with OI in the audience who say, well, I still break. Fair enough. But I think that, that in general, we see I see adults with OI fracturing at a lower frequency than children with OI. But this can be a little challenging. I find that experience of pain, functional limitation is the most common reason why adults even come back to clinical care to have this discussion. And then bone mineral density, again, it's something that I follow. It doesn't weigh in by itself quite as heavily. And in adults, I almost always use zoledronate. I have a couple of people who have just not tolerated zoledronate, and so we have them on pimidronate, but I almost always use zoledronate in the adults. I like the convenience. I like being able to do one-stop shopping. They come see me. They get their zoledronate dose later that day. A lot of their OI specific care is done in one day. That's very nice to be able to give people a little more convenience. And I still use weight-based dosing in adults, by the way. I think of many of our patients with OI are smaller. And so I think the standard 1 or 5 milligram dose, I think a lot of times is just too much drug for people. And so I tend to give them a single dose of 0.05 milligrams per kilogram. I used to give it annually. I don't really do that anymore for most of my adults. I do what I call on-demand dosing. This kind of comes to, how adults are not big kids. Cyclic bisphosphonates make sense to me in growing skeletons. If the skeleton's still growing, if you're still adding linear growth, it makes sense to me to do cyclic bisphosphonates. But I think that for our premises of adult care, I've historically borrowed from the pediatric care, but it's a different disease, or it's a different manifestation. And because we really don't know as much about fracture reduction in adults with OI, I feel like I have to level with my patients that this is not, I can't promise them that bisphosphonates are going to do the same thing to them as we think it does for the kids. But I still hear about bone pain, and I still hear about joint pain. And so if we're concerned about the pain, let's treat this accordingly. And so my goals are different. And so I think that in that case, I think, the time at which we treat patients or adults with OI, maybe it should be more of a when are you having pain? If you're responding to bisphosphonates, and about half of my adults with OI do respond to bisphosphonates in terms of their pain improvement, then we have them tell me when it hurts and when it doesn't hurt. And if you don't do well with the first couple of infusions, probably doing a third infusion is not a good idea. But at least we've given it a try. And so generally speaking, when I've offered on-demand therapy to adults with OI, they've generally been pretty responsive to that. And what I've noticed is the time between requests for infusion has lengthened. So instead of giving annual doses, I'm generally spending about 20 months or so between infusions, and kind of the range has been between about 12 and 30 months for adults who have responded to bisphosphonates. And as far as I can tell, we have a very similar impact on pain as what we were doing annually, and we're giving about 40% less drug. And I like the idea of getting by on less drug if we can. We are still seeing increases in bone mineral density. Again, I don't have a head-to-head comparison for these adults, but at least from what we're still seeing the increases in bone mineral density for people. So my hope is that we're achieving much of the same goals, but we're doing so with fewer infusions and overall less drug. That's my hope anyway. So in conclusion, I would just say, there's still a lot we don't know about the benefits of bisphosphonate therapy. We know quite a bit, but there's still a lot we don't know, especially in adults. I think the data is clear with pediatric patients within adults. And if there's one thing to take home of this is, again, this is just the opinion of, one guy practicing in the middle of the country. And so there's no perfect way to treat patients. These methods this worked for me okay, but some of it's been response to my own clinical experience, and a lot of it's been talking to my colleagues, a lot of great colleagues, a lot of them are in the audience here, and they have their own experiences, and I try to learn from them as well. So there's definitely no one perfect way to treat patients. And I will say that treatment and decisions are becoming more complex. Now that we have approved and investigational therapies that are different from bisphosphonates, I think that's going to enter into our discussion. And I think that trend's likely to continue. And I think we're going to be 5 years from now, we're going to be having a very different discussion of this type. So thanks, everybody. Thank you, Laura, for inviting me to give this talk. I really appreciate that. This has been a talk I've been wanting to give for a while, and so I appreciate it. And unfortunately, I'd like to stick around for the happy hour with Dr. Bober and company, but I have to get back to clinic here in the next couple of minutes, so I'm sorry for that. But thank you. Laura, are you with us still?
Yeah.
Dr. Tosi, you're
Yes,
still.
I'm right here
Here we
talking
go.
away to myself.
Oh dear.
As
Okay.
you might expect. Can you hear me now? Right.
Yes.
So since we're going to lose you, I do want to respond to one of the questions in the chat box.
Yeah.
And I just want to thank you. This is such a complex topic. There is no right answer, but you gave such breadth to the nuance of it all and the importance of age and change, et cetera. Terrific job. We do have an interesting problem. Dr. Artemis, I'm sorry, I'm going to clobber your last name, Dulgaraki. from Greece has said, do you have experience with Zoll in kids less than 3? Because pamidronate, interesting enough, is no longer available in Greece.
Yeah, that's a wonderful question. I do have experience with Zoll in younger patients. What I've generally done in the younger kids is because I like giving it a little more frequently. I've generally done it every 3 months. I like that. I like kind of the, physiologically, I feel like it kind of makes sense to do it. I usually do 0.025 every 3 months for the kids who have a little more involved disease. But I think it works okay. Again, my experience has been that for kids with a tendency for more bone pain, I feel like maybe it's a little more anti-inflammatory effect from the pamidronate. I don't know, but I feel like maybe we could just get a touch more mileage out of it. But I think if you can't get pamidronate, I think doing zoledronate every 3 months in the younger kids is a totally reasonable strategy.
And one other quickie, would you be willing to put your protocols online?
Yeah.
And actually one more from Mike Bober. Do you ever measure bone markers to determine your dosing frequency?
Yeah, that's a good question, Mike. If a patient is clinically well, or if I feel like there is a clear path forward on their clinical presentation and their response, I don't generally do bone markers for dosing frequency. If I run into a clinical quandary, a patient is, maybe they have a very good bone mineral density response, but their clinical response is not so good, or vice versa. They have an excellent clinical response, but maybe we've only gotten 2% increase in their bone density. Sometimes in those cases, I do bone markers, but I don't do it as routinely. Maybe I should, but I really don't.
Great. Thank you so much for making time and staying a little extra. It was a great talk.
Yes, thank you.
I am going to push us along to keep us on time, but thank you, and thank you. So it now gives me great pleasure to introduce a new member, really, of the OI team. Chaz Kellem is a member of the OI community and has come on board as our diversity, equity, and inclusion consultant. And in fact, today he's going to speak about diversity and inclusion in OI care. How can we support the entire community? And I was very tickled that he took this on because we have been very concerned, and I'll allude to it more, that so often we are not speaking to the entire community. And we want to be sure that we do. So Chaz, thank you so much for being with us today.
Yes, good afternoon, and thank you so much, Dr. Tosi, for allowing me to take some time here. I also want to thank the entire foundation staff and the entire OI community for taking your time today, wherever you are in the world, to join us for this exciting event today. I'm thrilled to be here to represent the engagement side of our work with regards to the OI community and how we can really collectively work together to make sure that our resources, our knowledge, and our overall experiences are impacting the entire OI community. So first, I think it's important to share, well, who is this guy, right? Who is this Chaz Kellem guy coming from nowhere? Well, I am a member of the OI community. I have OI type 3. I'm born and raised in Pittsburgh, good old Western Pennsylvania. And, our OI community here is thriving, but our medical side has been behind. We really could use some additional support here. And I have been doing DE&I work for 10 plus years. I have degrees from 2 local institutions. My full-time job, I work at the University of Pittsburgh in a student affairs role where I am providing service experiences to our University of Pittsburgh students. And I do this DE&I work because I love it and I'm passionate about it. And, as a member of the OI community, was thrilled at the opportunity to work with the team, with the medical community, and with the OI community overall to do this work. So here's what we're doing. We are in phase 1. So I've been working with the foundation since the start of February, and we'll be working through phase 1 through the end of June. I'm not going anywhere at the end of June. That's just what we're calling phase 1. So I'm still going to be around, driving Tracy, Erica, and Dr. Tosi a little nuts, but I'm going to be around. And our goals for phase 1 is to do an assessment of the programs, activity, business structures, volunteer programs, really to look at identity and identify areas of weakness in programs, materials, and staffing. And please know, that's not assuming there are weaknesses, right? I'm not going into it looking for things. That's just making sure that we identify and we're open to those weaknesses. And this is really a research phase, right? What are we currently doing to support and engage our entire OI community? We first have to pause and understand what we do, understand who we are, understand where we are, establish some metrics for success in order to keep us moving forward. And why? You're probably thinking, well, why? How does this connect to, the work? Well, we want to support the entire community. And, after talking to many people, we support a lot of people and we engage a lot of people, but we miss a lot of people as well. And this, folks, is not just a black-white conversation, right? As we think about diversity and inclusion, it's not just to support our members of our Black community around. It's to support all people, right? So age, sexual orientation, members of the LGBTQIA, our Black and brown brothers and sisters around. We want to make sure that everyone with OI, regardless of where they may fall in the diversity and inclusion, equity sphere of life, are supported by the foundation, have access to the foundation, and know we are here to support them and providing the best quality of life and care possible. So here are some goals, right? There are lots. I've listed 5 to start, right? We want to involve our OI community to reflect the demographics, right? So as we look at the foundation and how we do work in the community, we want to make sure that it reflects the demographics of the city, of the state, of the country, of the world, right? Wherever you are joining us today, we want to make sure that it reflects the demographics accordingly. We want to make sure members of the OI community are aware and can access the full scope of services, as I mentioned. We want to involve, make sure that our community is impacted and can be involved in all levels, and that DE&I is encompassing all levels of the foundation. We want to make sure that every OIF member of the community, board, staff feels included, right? And that word "feels" is in there intentionally. You can evaluate and monitor feelings, right? You can evaluate that, and we're going to be doing some of that, and we've already started some of that work. And we want every obstacle, to resources and opportunity is clear for every member of the community, right? So we've learned, as Karen mentioned, the impact of COVID. Well, it has removed some barriers while it's provided some additional ones, right? So we want to make sure that all of those barriers and obstacles are removed for every member of the community. And the whole goal here, folks, is liberation. We want every person that is a member of our community to have full access and scope. We want to remove the fence, right? Many of you, probably have used equality. Some of you may use equity, but the reality is that the, Black and brown and marginalized community, Black and brown and marginalized members of our world are behind, right? And are not accessing and living to the full scope possible. We want to make sure through the work of this DE&I, which again, I want to applaud Tracy, the entire OIF team, and the board have committed to making sure that we get to the end here, where we are removing every barrier to make sure that every member of the community is incorporated. And folks, it takes all of you, right? Especially members of the OI medical community. I need you, right? As you're engaging with patients, to understand that, it's important for us to see doctors and members of the medical community that look like us. It's important that you understand the connections of all of our identities, right? So I need you as part of this process. And here's why, right? Here are some reasons why and how you can support. I want you to see the entire community, folks, right? I'm not a patient. I'm a person. I'm a person. For me, you saw my picture. I know I'm handsome, right? But I'm a Black guy that uses a wheelchair, lives in Pittsburgh. I want you to see the whole me. I want you to listen to all of our community, right? So if you are in a city where you're seeing majority of members of the OI community are white, I would ask you why. You know, do Black and brown members of your community know that you exist and you have specialists and experts in your community, right? Create those opportunities for engagement. This is not Field of Dreams. If you build it, they will come. That does not work here, right? DE&I has to be done intentionally. It has to be done authentically. And we have to do it through a transparent lens. It takes work. Again, we have to understand the intersection of our identities, right? We're more than just our OI, right? We're brothers, we're sisters, we're husbands, we're partners, we're community members, we're stakeholders, we're board members. We are more than just our OI. And we're not all the same, right? Every speech I give around the country, I tell people I'm not speaking for all Black people. I'm not speaking for every member with OI. I'm not speaking for every person with a disability, right? We're all different, and that is part of diversity and inclusion, right? If you think about the iceberg below the surface, there's a whole lot to a person, and those things are elements of our patients and our members of the OI community. And at the end of the day, I want us to use our collective voice to help build self-advocacy and self-determination skills, right? I want every member of the OI community to have their voice heard. I want that person to get whatever he, she, or they may need to be happy. And I want them to determine that, not the medical community, not the members of the foundation. I want that person with their self-advocacy and self-determination skills to advocate for themselves and be happy in the skin that they're in. So I'm coming to you today as a member of the community, really not talking about the medical piece, but the life piece, which is directly connected. If I'm in pain, I can't live a full life. If I'm not being treated medically properly for my fractures, I can't live the life to my full extent. So the two, folks, are very much intersected together. Here's what we're doing next, right? Or here's what we've done already. So February, March, done a lot of research, created tools to help us through this assessment. Every member of the OIF staff has been interviewed one-on-one, private, confidential conversations. I learned a lot about each of them. Folks, we have a great team at the foundation. If you don't know them, please connect with them, use their resources and their knowledge. I've attended a variety of special events. Again, thank you, Dr. Tosi, for allowing me to join today. And we have more of those coming down. Here's what's next. I am right now in the process of interviewing various OI stakeholders and community members, right? We have some dynamic people around the world that I've had the honor to talk to, right? Lots of personality, smart, brilliant members of this OI community. I'm engaging with members of the OI community that are total strangers. So I'm meeting people on social media. I'm meeting people on TikTok. I'm making friends everywhere, folks, because I want to know with members of our OI community that aren't connected to the foundation, why not? We're going to be doing a staff cultural humility assessment. That'll be done here soon. We're going to be doing training, board engagement. We're doing reviews of the bylaws, the policies and procedures, the website. A lot of work ahead over the next 3 months. And I'm excited to go on that journey. At the end, there'll be a final report that'll be submitted to Tracy and leadership in early July, with my work officially wrapping up at the end of June. In that report will be some next immediate steps, some recommendations, some suggestions, some strategies for stakeholder development. But again, I can't stress enough that this takes all of us, especially members of our medical community. There's my information, folks. I want you to participate. If you're interested in talking to me, you want to do a quick interview, 30 to 45 minutes of your time. Talk to me about your experience in diversity, inclusion, and equity. What type of patients are you seeing or are not you seeing? Why do you think that is or is not? Do you have resources in various languages to support that? What are some strategies that your institutions have used that have been successful? Connect me with families, right? I want to talk to people. I want to understand the challenges and obstacles associated with diversity and inclusion directly connected to their medical diagnosis and prognosis. So you know, I need you to help me connect with our community. I need your ideas. I need your suggestions. So please connect with me. I would be happy to talk with each and every one of you in some ways to help move this effort and this initiative forward. And I just want to conclude by stressing that this is not going to be done in June. This is not going to be done by the end of 2020. You know, Tracy and team understand this is a process, and this is going to take some time, some energy, and again, we are on the right path. So thank you very much. I look forward to talking with you, some of you, more in the very near future.
Chaz, thanks tremendously. That was just great, and just the message we want to send. Appreciate it a lot. To keep us as close to time as possible, I hope you'll join us at our free-for-all. I think we can say that better, but free-for-all at the end. And I'm going to just push right along to give my own little chat because I want to. I do want to say that I think Tracy was brilliant to bring Chaz on board, because some of the things I'm about to talk about really interface with his efforts. So I'm tickled my slides are working. The reason you're here in a large part today is just my own personal journey. I know many of you, but not all of you. I've practiced in Washington, D.C. Thank you for your tax dollars for more decades than I want to admit. And I've been deeply concerned that I have no place to send many of my adult patients. Travel is very difficult for a lot of my folks. And I think most important as an orthopedic surgeon, which is what I do all day, is that we've worked so hard to improve those skeletons, make people as independent as we possibly can, but we don't really know what to tell our patients about the future. So that drove us to apply for a PCORI grant. And the Patient-Centered Outcomes Research Institute is a fantastic group here in DC who are really interested in patient-centered outcomes. That their belief is that it's the patient who knows what they need and that they must be the ones driving research, care, and information. So our little project is called Improving Patient-Centered Outcomes, Expanding Engagement of the Osteogenesis Imperfecta Community. It was launched just 2 years ago. We had great plans. We wanted to teach what we call PCOR to lots of folks, improve our communication, develop a OI-specific PCOR toolkit, and also be sure we were helping other rare bone diseases. We got a good start. We got generous support from the OI patient caregiver community in populating our many communities. In all honesty, and I'm sure glad you're here today, we got a terrible response to our OI clinic survey as we tried to figure out what clinics needed and wanted and how we could be more helpful. The OI Foundation had a registry that had been ongoing for 20 years in various modes and models, but that got temporarily disengaged, so to speak, when one of our NIH U54 grants, which is a longitudinal study of OI, said, nope, we're not going to support OI registries anymore. We felt that this was absolutely critical to helping define particularly adult care and the future. And so Tracy leapt to the fore and made that new again. And we'll talk about that a little bit more later. Tracy made a particularly big effort in terms of making sure we talked about engaging patients at our multiple regional meetings, et cetera. And then COVID struck. Now, I personally remember exactly when the lockdowns were given because I flew out to Phoenix to give, in fact, a PCOR talk on a Friday. And by the time I got there, the hospital had sent out a mandate, no one can leave town. So then I had to start begging that they would let me come back. The incredible versatility of the OI Foundation was then demonstrated. We were supposed to have our first PCOR training session just a few weeks later. And what were we going to do? Well, the fabulous OI staff turned our planned in-person training into a virtual event, and thus we weren't paying transport anymore. We could have involved far more people. And in fact, we had 3 times as many participants as planned. And many of the folks on this call participated, and I thank you. This was an aha moment for us. So at the same time, good old PCORI came up with a new grant, which was a COVID-19 supplement. And this was put out to sort of try to help communities deal with the isolation and social distancing. And we applied and we were thrilled to get that as well. We pledged to expand our virtual meetings, create and disseminate COVID information, use our registry to document and track what are the issues for the community, gather information on therapeutic options, and develop more tools for the community. Well, again, Tracy and team stepped right up. They initiated community calls, 30-minute didactic presentations with all kinds of medical experts. And we've had a dozen or so since the start, not just COVID-19 and OI, but preparing for telehealth, orthopedic perspectives, healthy eating, mental health, whatever. And the beauty of doing it this way, each call was recorded and posted on the OI Foundation website. And we've already had more than 4,500 collective views. We piggybacked on or created new virtual meetings. One of the other aha moments was the national conference. Typically, we get 600 to 800 folks registering. Well, it was free this past year, and we had 900 registrations. And the exciting thing was more than half of the folks on that call had never attended an OIF event. We did a brief survey, and folks made it clear that removing the financial, physical, and time commitment barriers made it much easier for folks to participate. And we were able to continue our PCOR training. One of the interesting issues was we were finding this is just great, but we're really not talking to the various OI clinics out there and giving them assistance. As you may know, from years, we just had 10 OI clinics nationally on the website. Well, we're now up to 50, but we don't really know who you all are and whether or not we can be helpful. So we decided we'd try a virtual town hall. We had our first meeting in September, and we were thrilled by attendance and by the opportunity to talk to many of you. And I certainly welcome those of you who are on board today. One of the things we also have been working hard on is our OI registry. And this Deb Krakow needs this. I want everybody to support her. So be sure your patients are signed up. Right now, we have just short of 2,000 individuals who have signed up. About 80% are from the US and 20% or so are international. They are across the age span. And we want to be sure that folks are not just registered, but that participating in our surveys, because this is how we can really turn information around for the community in a quick and important way. I hope you all get the OI breakthrough. And as Cara said, we will be doing our second survey report in the breakthrough that should be coming to you in the next minute or two, in the next week or two. And it's the beauty of the internet and internet data gathering. Our data may not be perfect, but it really gives the community a sense of what's going on. And I think and hope also that we are helping to deal with the issue that so many community members have expressed. I participated in a study and I never found out what happened. Well, we are trying to be sure that our survey results are up and out as quick as possible. And our next survey, which will be coming out this summer, will hopefully deal with the fact that so many of our folks who have gotten COVID seem to be having the long COVID symptoms. We are tickled, as you heard, that 34% of the community has been vaccinated, and we hope that continues to grow. We are deeply concerned because people have really fallen off on their exercise. What you're seeing there is that greater than 60% of folks say that they're exercising less. That's bad. Orthopods say movement is life, and we really mean it. And so Tracy and her team are working on an exercise community call that will be coming up, and I hope you'll alert all of your community members to it. We found some real issues with the survey, and this is why I'm so glad that we had Chaz on here. The fact of the matter is that about 70% of our respondents are women, so we need to get the guys involved. And perhaps even more important, 95% are white. That's no good. And we want to represent the entire OI community so that we know what steps really need to be taken. As I said, we're going to be working hard on long COVID symptoms. We'll be tracking the vaccine rates, lots ahead. And we would be very grateful if you would alert the folks in your clinic to really participate in this, I view, opportunity. As folks who are in clinics, we hope you'll work with us. Read about what we're doing in Breakthrough. We have developed on the OIF website important things, our COVID toolkit, our PCOR toolkit. You know, I had a request from Saudi Arabia last week. What do we do about should we take the vaccine or not? And it was so great to be able to say, yes, get the vaccine, but read up on the COVID toolkit. We hope that more of you will want to participate in PCOR training because we have more projects ahead. As I said, please urge patients to sign up for the registry, and we hope you'll want to continue to participate in our town halls. And let me break for a moment to do a small update. Remember, at the very beginning of this call, we will do a survey at the end, but oftentimes people don't fill them out. Would you, in the chat box, tell us who you are, what you do, because we want to know that we're helping everybody in the community and in the caregiver community with questions that they want answered. And we want to know evening, short format, afternoon, longer format. What do you need and what information aren't we giving you? Looking ahead, well, we're committed to tracking this COVID deal. There's so much happening and it's so important to our folks, given the increased incidence of pulmonary issues in OI. We're working hard to expand our support to other rare bone disorders. Our next expansion, so to speak, will be exploring opportunities to improve transition for young adults and access to care for older patients. And as we have emphasized so often throughout this presentation, we really want to be sure that we are reaching the entire OI community. I want to have a moment to say thank you. Our committee, our leadership includes Marg Birdwhistle, parent of someone with OI, former board chair, Michelle Dupre, patient with OI, former board chair, Cameron Penn, current board chair, all stepping up to lead our committees. We added a COVID task force, and we were amazed and pleased by the diversity of folks who wanted to help us. And note again, in the tradition of PCOR and PCORI, we felt very strongly we have to engage the community. The grant is led by myself, Tracy, and Bryce Reeve, who really leads our P-Core training. So I think research has really changed. You know, in the past, one decided what marker they were going to follow and tracked it along. I think the priorities are changing. We are thrilled to engage the community. We believe strongly that the clinics are an important way to ensure that all patients with OI are getting the best care. A great term for those who have participated in a tele-echo, democratizing healthcare. I really believe in it. And I believe with these new opportunities that ironically COVID has brought us, we can really do an even better job going forward. So thanks tremendously for your time. And now I will unshare. And it gives me great pleasure to introduce Dr. Deb Krakow, who is going to talk to us about pregnancy in OI. And she has a lot of important messages for you. And of course, I dropped my notes. But Deb is professor and chair of OBGYN and professor of orthopedics as well, which I just love, at UCLA. Deb, thank you so much for being with us today.
Thank you. It is just such an honor and pleasure to be here. And I'd just like to briefly sort of echo everyone's sentiment. It's just it's so rewarding to all of us to see so many people participate and share in what's a real community for me of longstanding. I'm going to share my screen. Can everyone see? Are we good? Erica, you're nodding your head. Okay, so thank you for the invitation, Dr. Tosi.
You got to switch the to the presentation mode.
Oh, presentation mode, sorry.
You know, I mean, they switch the screens in the upper left.
Oh, you're right.
Yes.
Thank you, Dr. Sandhouse, again, telling me, keeping me on track. So I'm really here to talk about pregnancy and OI, what we know and what we need to know. So, you know, I think to this audience, you know, we know what osteogenesis imperfecta is, but I think as time has gone on, beyond the really importance of bone, which is really of paramount importance, we really are beginning to look at things as people have talked about in terms of pulmonary compromise, deafness, you know, cardiac valvular dysfunction, glaucoma. And for me, what's really, really important is understanding osteogenesis imperfecta in a woman who has it and would like to have reproduction, would like to have a family, which I think all of us support and is very important to us. And sometimes in our community, we realize that many of the providers who take care of people while they're pregnant, obstetricians, may or may not have ever seen anyone with OI in their career, and that we want to sort of dispel any misperceptions. So we did a study, and we wanted to look at what were the outcomes of pregnancies associated with maternal. The mother has OI. And so we wanted to determine whether some of the myths that people with short stature shouldn't be pregnant, people who may be in a wheelchair shouldn't be pregnant, or are the outcomes exactly the same as the average stature population? So we designed a survey. It was retrospective, and for those of you who are interested in surveys, retrospective surveys are great. They're not perfect because you're relying on people's memory. We contacted the people in the Brittle Bone Disease Consortium contact registry. And so Dr. Tosi made a lovely plug about please joining any of these registries, particularly this one, so we can survey the community on their outcomes. We had an extensive questionnaire for each gestation, and we are happy to report that 132 individuals responded, of which represented 170 unique gestations. And this was self-reported. So the people who reported determined by themselves whether they were mild, moderate, or severe. So again, echoing what Dr. Tosi said, 97% of our respondents were Caucasian. This does not completely reflect the CDC data that says that 54% of deliveries in the US are to Caucasian women. The median height was 54 centimeters. So I would say some mild short stature. 75% reported themselves as having mild OI, but 25% reported as having moderate to severe OI. And I think that this is really important. While there are other studies that are elegant and well done in OI and pregnancy, this is the largest cohort of individuals who actually felt that had pregnancies that were moderate to severe. There was only one individual who reported that their spouse also had osteogenesis imperfecta. So what we did was we looked at data where what we could say from a survey was that there was established data in the general population. So I think what we were trying to say was, are there large cohorts in the general population that we could rely on? So we weren't just sort of subjectively or, just touching on things. And I put arrows on areas that were really important that came out as statistically significant. We saw an increased incidence of gestational diabetes in individuals with OI who were pregnant. The one below it, which is the arrow that says need for transfusion, and I will get back to that. There was a marked increased need for transfusion in women who had OI and who delivered. The rate of cesarean section was increased against the general population. I don't find that surprising. The incidence of regional anesthesia, epidurals and spinals were actually less than the general population, which suggested to us that either women were not getting regional anesthesia or perhaps getting general anesthesia for delivery. There was an increased incidence of NICU admissions, irrespective of whether or not the fetus themselves had OI. And there was also an increased incidence of infants with low birth weight or very low birth weight. And there was an increased incidence of neonatal mortality, which infants died before 28 days of life. And again, this was not correlated specifically to the fetus having OI. And there was an increased incidence of breech presentation. There were some other interesting data, which is actually in the OI community, there was less individuals who noted that they had an abortion for any reason. There was an increased use of artificial reproductive technology. We are assuming that this was because people chose not to have children with OI, or perhaps there was increased infertility. We're not able to decipher that from our data set. And that actually, to me, most surprising, that women who have OI who are pregnant use less medication or reported less medication use in the general population. I'm also happy to report that if you look at the rates of breastfeeding, which is a very important indicator of maternal outcomes, the women with OI who had children breastfed at the same rate as the general population, though less did at 6 months. These are the neonatal characteristics, the median birth weight, and there were other parameters here. As predicted, given that more than 85% of individuals with OI have a dominant form of OI, which would mean that they have a 50-50% chance of passing OI on, that 47% of about, 47% of the children did not have OI and 48% did, which fits with what we would believe. But there were increased NICU admissions, and there was an increased incidence of children who did not survive beyond 28 days. the cesarean section rate was, of course, increased. I think that there was also very interesting things to talk about the resilience of our community. The incidence of individuals who were treated for postpartum depression was not any higher or lower than the general population. And again, I reported that individuals breastfed. So to me, the most important thing and the main reason why I really want to talk about this study, and we are following up and going to do another survey. If you look, there's only one paper on the incidence of fractures during pregnancy, and it was a large retrospective cohort out of Australia, where they looked at the incidence of fractures that were reported during pregnancy. And in that study, and there were over 48,000 individual pregnancies, all the fractures in pregnancy were in individuals who sustained some trauma. But in our cohort, there was an increased incidence of mothers having fractures in the third trimester or in the first 6 weeks of postpartum after delivery. And what was interesting to us, that there was no difference in the type of OI that the mother reported. So those individuals with mild OI had the same incidence of fractures as women who had more severe OI. So sort of in conclusion, what we can tell about women who had OI, whose children also had OI, which is the 50%, that having a fetus with OI did not cause the mother to have more fractures, that they did not experience a longer or shorter pregnancies. Their infants were of smaller birth weight. They did not experience more or less depression. They were, I don't have an explanation why, but they were more likely to deliver vaginally, but they were less likely to receive an epidural. And this is why we're going to do a follow-up study, because we're trying to understand why we received some of these responses and to understand if there are any biases in care. But this goes back to what we were talking about, was that 10% of our women reported fractures during pregnancy or in the immediate postpartum period. And there were an increased incidence of vertebral fractures, particularly in the postpartum period. And as I said, the incidence of fracture in the non-OI women is very low. So the relative risk of fracturing postpartum is 388 to 1. And this is where we're really going to look to try to encourage our next survey, where we're going to contact the women and get medical records, is to understand if this is a period of time that we as physicians are not paying attention to, and if there are any interventions that we could think of as a collective group to make it better for our patients. So maternal mortality in the US remains a clinical issue. Last year, over 700 women died in the postpartum period. And the most common cause of maternal mortality remains hemorrhage. It is 11% of maternal mortality. And I will say, sadly, the next causes include hypertension. And the fourth most common cause includes depression, suicide, and homicide. So I think we still have a long way to go, but I'd like to talk about hemorrhage. The transfusion incidence in the US for all comers, all women who are pregnant, is 0.5 to 1%. And in our OI cohort, which I will remind you that 75% were women who perceived themselves to have mild OI, the incidence of reported transfusions was 8.3%. By no means am I saying that we should not do anything but encourage people, as I think Mike Bober talked quite elegantly in his first talk, about understanding what the patients want from their pregnancy outcome. But the most important thing for me is to make their awareness that women with OI actually have an increased incidence of reported need for blood transfusions, and that we don't ignore this, and that we educate providers on this in the immediate postpartum period. There are treatments that can be used, and one of them is tranexamic acid, where we could actually potentially educate our colleagues that if a woman with OI starts to bleed postpartum, don't wait till you need blood. Try to do maneuvers that can decrease hemorrhage, that you may wait longer in a woman who doesn't have OI in terms of bleeding. So I always remind myself, this is one of my patients of long standing. I'm not allowed to say that. I always say that because she is old. She always teases me that she's old. But she was a woman who I saw who was 4'10", and she had no fracture history. She had no DI. She had mild hearing loss. And she reported to me that her first child died of a skeletal dysplasia. No one could tell her what it was. And when I saw her, you know, to me, she looked like she had very, very mild OI, though she never had a fracture. And we actually could show that she was mosaic for a COL1A1 mutation, and that these are ultrasound images of her fetus that was actually quite severe. I don't know if they're coming up well, but it was quite severe in the first trimester. So again, I always remind myself to don't forget about mosaicism when you're taking care of pregnant women. Our goal, and again, thank you, Dr. Tosi, for the plug, is we are going to do a recontact survey. We are going to contact patients and actually obtain medical records and do one-on-one phone conversations with them, so we can have a better understanding of the following focuses that the patients have complained to us about, which include fractures, hemorrhage. Many women who I've taken care of, and I would like to hear from the group who have taken care of women with mild OI, the patients report that they had pretty severe tissue lacerations if they delivered vaginally, and that they had decreased healing. That we usually tell people who have vaginal tears or episiotomies that they'll feel better within 7 to 10 days. And many of our patients have reported that it's taken longer than that. Please, 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 please encourage your patients to enroll in the Link Clinical Research Registry. And this is a personal plug. Please, if you know any patients who have had osteoporosis of the hip in pregnancy or postpartum period, to please contact the OIF. We would really like to talk to them. This is a very, very rare complication, and we would like to know the incidence of it in the OI population, because it can be life-threatening. So I want to thank you for your attention. This is me, and now my junior faculty member who started this project when she was a fellow, Rashmi Rao, and this is us at one of the OI conferences. And you know, she has stayed, you know, interested in the field. And is participating in the next phase of our study. So thank you for your attention.
Deb, spectacular. I am going to quickly ask you to respond to one of the questions in the chat, because I think it's important, which is, do you have any data on the postpartum fracture rates in women who breastfed versus those who didn't?
The greatest question. And based on what we did by correlating the surveys, we did not see a correlation between breastfeeding and not breastfeeding. It is a great question, because in the third trimester and in breastfeeding, the calcium that goes into the breast milk comes from the maternal skeleton, not from the GI tract. And so I am still remaining an advocate for breastfeeding. Now remember, 75% of our women did breastfeed. So we may not have had a large enough power analysis to actually determine if there was a difference, but I'd like to hear what my colleagues think, but I remain committed to people breastfeeding. I think the benefits outweigh the potential risk.
And one more quickie. Erin Carter asks, did you ask women with OI about increased dental issues during pregnancy?
No, but Erin, if you feel that this is something that you're hearing about from your patients, we would love to know more.
Great. Okay, we're not on time, but we're pushing. All right. I think the issue is there's so many great things happening, and sometimes you just don't know. I know I've had a challenge over the years that I had to make long distance phone calls for help anytime I had problems in the OR.
Yes. Hello, everyone. So Michael Stewart is going to show the slides. So here's the information about the OI Tele-Echo Clinic series. So this is a once per month, 1 hour session where there is first an invited speaker who talks about 20 to 30 minutes. And after that, we discuss the presentation, and then there is case presentations and discussion of the cases. So each month there is a different topic, and the faculty members that are shown here have made the program. So the program is always made 12 months ahead of time. And so we have for now the program until I think September. Next slide. So here is the entire year's program. So the ones with the red boxes have already occurred, but don't despair, it's not too late. You can still see the presentations on YouTube, and when you go on the OIF website, you can see them there. The upcoming are the ones without any boxes. So you can register on the OIF website or send an email to Michael Stewart. And also we have to soon decide about the program for the next 12 months. So if you have an idea of something you want to hear about, you could send an email to Michael Stewart for suggestions.
I'll put my information into the chat in just a moment.
Yeah. Okay, I think this is about it, about the Tele-Echo.
Thank you.
That's great. Thank you so much, Frank. And there's just a, oh
Quickly,
no.
I just wanted to do a plug for the Rare Bone Disease Echo as well. Also, so this is hosted with Dr. Tosi as our chairperson for this. As many of you, I'm seeing lots of familiar names. So I think many of you have already attended Rare Bone Echo meetings already in the past year and a half. This is the first Thursday of every month at 3 p.m. Eastern Time in the same format as the OI Echo. This is a copy of our flyer, which you can find also on our website. I'll include this information in the chat in just a moment. But as you can see, we've done already many of these sessions already. You can find them on our YouTube channel. And up next, we have DEXA evaluation in children with Dr. Gordon. And Dr. Tracy, am I missing anything?
No, that's great, Michael. I'll push us along. I'd
Okay.
now like to introduce our fearless leader, Tracy Hart, who's just going to bring you up to date on even more learning opportunities.
Thank you, Dr. Tosi. I'll be very quick because I can't wait to get to the roundtable. And just many thanks to everyone for today's presentations and for being here. We appreciate it so much. We talked about some of these programs before, but I really want people to visit our website, look at the information on our national conference coming up July 10th and 11th. It's virtual, so please, 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 encourage your patients to register. It's free. So we'd love to see as many people at our national conference as possible. Jess Ransom is our health educator. She's on the line. She's been putting in information. She would be happy to talk to any of your patients at any time about, connecting them with resources. We have an impact grant program that helps fund things that insurance doesn't fund. So that's on our website as well. We talked about Tele-Echo. We do have a Young Investigator Fellowship Program. It's called the Michael Geisman Fellowship Program in honor of our founder's son. So we just closed our fellowship for this year. Applications will be due again in November. We're also a member of the Rare Bone Disease Alliance. That information is on our website as well. And look for information coming up on a Young Investigators Symposium that will happen in September. Erica, remind me, I think we have a date.
September 9th.
September 9th. Dr. Joan Marini is chairing that. So we'll have lots of information on that on our website as well. So there you go, Dr. Tosi, on to the roundtable.
That is just great. So I'm just going to make a inappropriate comment. For all my invitations to please give us your name, etc., not a single person has written to us really, except at the very, very beginning. So I do hope you will fill out our survey at the end that you will get in your email, because we do want to know what you want. We think that working together, we can be more successful. Now, the final section, technically feel free to sign off at 4 o'clock Eastern time, but we will stay on. We will dedicate everything to OI clinics until 4 o'clock, and after 4 o'clock, we're open to anything. It's truly Friday afternoon. But one of the things that has really struck me as we reach out to your clinics is there are so many ways to skin a cat, that we all make different choices and we all have different opportunities in how we run our clinics. But boy, is it good to brainstorm and see how other people do it. And I will just tell you, I couldn't possibly do an OI clinic as a dedicated event, but I do a bone health clinic every Tuesday. So if my patients have a problem, they know, if possible, wait till Tuesday and she'll add us on. But there are so many different ways to do it. And so we have 3 speakers who are going to talk briefly about how they do it. And then we hope that we'll have significant impact and input from the chat box. So first, I'm going to introduce Dr. Paul Esposito, who is professor of orthopedics and pediatrics at the University of Nebraska, and heaven help him, surgeon in chief for that hospital. A very tough job. Paul, thanks so much for being with us. I know you're there.
I know. It's Friday afternoon. It's happy hour, everybody. Okay. I should be sharing screen now. Is that there?
We're great.
Okay. So that's the beginning of the talk. Okay, here we go.
I'm not seeing a shared screen. Sorry.
Okay.
Oh, okay.
There we go.
My apologies. So I think what we're going to do is say, what do our parents and family want with us? And this is going to be somewhat a scientific experiential consideration. I didn't exactly know what we were going to do here. So just going to tell you how we did it here. We started in about 2005. One day, Dr. Plotkin descended in and said, I'm on your faculty. I'm trained in Montreal, and I've got these people who come to Omaha and show us how to do this if you're willing to do it. So we unabashedly adopted the Montreal protocol and their model with a few philosophical differences, because any of you that knew Dr. Plotkin, who's still very active in the research world, know that he has his own ideas. But I think that's good and that's healthy. So what we found is people want consistent, accessible, helpful information and honest answers to honest questions. And probably the biggest thing we hear around the country why they come to us is we're willing to listen and give them answers to the questions they have. And I think we all know that we have to respect everybody as a human being, and every patient is unique. And the ultimate goal, as everyone's been saying, is to help achieve maximum comfort and function. And that's different for everyone. And I'll just hit you with one of my pet peeves again, when we always say that type 1 OI is mild. There's absolutely nothing mild about a disease that gives you 15 fractures before you're an adult. So I would like to say that's less severe form. But how it should drive us, we should be sharing knowledge just like we're doing today. And here's Dr. Franzone and Dr. Wallace, who've been stuck with Dr. Cruz and I. We've had the pleasure of working with them, and they're unfortunately stuck with our bad dad jokes and occasional social gaffes. But we've learned probably as much from them as they've learned from us and other people around the country that have traveled to come here and for us to go there to share this knowledge. So I think that the biggest thing is we're all on the same journey, and we're all using our clinics to try and disseminate this information, with the OI Foundation, quite frankly, leading the way and giving us a structure to come together. And I just wanted to point out this gentleman in the middle is Dr. Ed Millar, who died a few years ago, but from the Sofeld-Millar procedure, which was a monumental change in OI care in probably the 1950s. That's the last one I did on the left. That gives you an idea. That's more incision and that child, and I don't want to gross anybody out on a Friday night, that's more incision than I've made in the last 50 patients. But that was the standard of care. So who drives patients to our clinics? I like to think, in the old days when we lived in communities where nobody moved for a generation, it was the grandmothers and the neighborhood nurse. Now it's all the mothers in the OI, through the OI Foundation and through their own social media groups. So, but who's on the team? I put this slide in because it's not only our team, but I think the most important people in this are the parents and the kids and the patients. There isn't anybody in here. Our research coordinator, our nurse coordinator is on this call too, and they're indispensable. Now, you don't have to have everyone in your clinic, but you have to have access to all those folks, I think, to do it well. And probably one of the most important persons in that group is a social worker. Because there's so many subtle things that we're not aware of that go on in school and the community that they're very helpful with. And who do you have to have available? ENT, if they have a lot of, obviously airway issues. Peds anesthesia, probably the biggest reason people come to Omaha that they tell us is that they come here and we do what we say we're going to do and we don't hurt them. We haven't had anybody admitted to the ICU for post-op problems. I think the key is working as a team and keeping your blood loss to a minimum, operating time down. And I've been blessed to have Dr. Wallace with me now, so we're probably half as much time as it used to take to do the same things. And having good pediatric surgeons to help you with hernias and venous access. Again, I think people need to, it's a personal decision as to whether or not you have a central line or not, but it can be a life-changing experience. So we like to see the kids prenatally. I've had one child I know that was told that they shouldn't be born, and mother sent a video to the therapist that when she was 18 months old dancing. So I think it goes back to what Michael was saying. We don't know what we don't know until we see people and work with them and make sure that we allow that family to bond and help their child become the best human being they can. And when do we do surgery? That's something people always say. It's, the parents and the patients tell us when it's time. When they start to walk, if they've got a lot of deformity, we deal with that on a very individual basis, and there's not one right answer. So I think, what do we still need to do? We need to keep talking, sharing, and learning. I think this group is marvelous. I think the most encouraging thing for me are the young people that are much smarter than I am that are taking it over. And they're working together. The video chats and things we've had have been astounding, and I've learned a great deal. And I think we have to recognize that not everybody can do everything. So we have to share with each other. And if anyone has any questions, feel free to contact us or the other places. I think Dr. Tosi's effort and the OI Foundation with Tracy and others to find out who all is taking care of these kids and make sure we all have access to the same tools is wonderful. So thank you.
Great job. Thank you so very much. So I'm going to push ahead so we can get our discussion going. It now gives me great pleasure to introduce Dr. Michelle Caird, who's professor of orthopedic surgery at the University of Michigan and interim chair of orthopedics. And she has a very different model that she's going to share with you now.
Hi, it's Michelle Caird. I'm going to try to get myself into presenter mode. And I may actually need some help, just like others were very helpful. Let's see. There. can everybody see that as a slideshow now? Okay, great, thank you. So, you know, what I'm at University of Michigan, and what I will show is that this has been our journey to a clinic really has been driven by a little bit by our location and a lot by our real interest in research as well as clinical care. So we're nestled between two shrines, and then between a bunch of lakes. And so in many cases, it makes it a little easier for patients to be able to get their care in the state of Michigan rather than a long drive. So based on that, we felt that our research really drove a lot of this. So I put a picture of my collaborator in our department, Ken Kozlov, and he is a materials scientist and researcher, and we were brought together to do clinic and research. And we felt like Ken felt like his questions were better, his research questions were better informed, and I always feel like our clinical decision making can be better informed by the research as well. So we always ask, will the answer to this question make a difference? And we can tell funding agencies yes. And I say, if we understand this disease better, can we design better treatments? And many times that comes through research. So thank you to this network and this clinical group for really pushing us forward. That's wonderful. So that's me, a little younger, a little less gray haired. Hey, Ken, check out this x-ray. And Ken thinking, oh gosh, I wish this were digital. But really what drives us, and this is folks like Michaela and her brother Austin drive us to these questions. And as Dr. Esposito pointed out, we really work to set individual goals with patients and their families. And this is, and for many folks, that is about maximizing function and mobility by whatever means is safest and most comfortable. And that's on the patient side, and then very deep down on a very small scale. This is really, for us, it's also about improving bone fragility, mass strength, and height. So that is us at one of our OI clinics, visiting the big house, or actually Chrysler Arena, with the basketball team. And that is something that we do in our clinic. So I'll just describe that. This is not all of our folks, but many of them. So we have, as Paul was saying, there are so many people to include in these clinics to really help folks. We have an audiologist and an otolaryngologist, both a pediatric and an adult endocrinologist. Ophthalmology has a pediatric person as well as adult specialists as well. Same with the dental school. We have our pain psychology team, and both pediatric and adult physical medicine docs. I've got my picture there, and I have a partner who treats adult traumas, who helps us with our adult OI patients, and Ken is there. We have cardiology, pulmonology, genetics. I don't have a great picture of our wonderful therapist, and because mostly she's usually taking the pictures of the kids and not letting her pretty face into the picture. So I'm sorry, Betsy, that you're not in here. But that's really our team, and multidisciplinary clinics were not the model when we started. So I went around and I worked with Inez Thomas, our peds endocrinologist, when she was a fellow, and I said, you have to do this, and bugged her until she said, okay, fine, I will do a clinic with you. And then together we went around to all of the departments and said, we know multidisciplinary clinics are not really where the focus is right now, but couldn't you give us a half a day twice a year and just do a clinic with us? Mark Hannibal is there from genetics. The geneticists all said, yeah, no, that's not what we do. And then Mark came to us afterwards and he said, I trained with Peter Byers. I would love to do your clinic. Just don't tell anybody right now. So this was very organic when we built this. But so many people joined in and were very excited. And a lot of that is around the care of the patients themselves, who are, just so wonderful. So we meet now it went from 1 to 2 times a year to 4 to 5 times a year, but each individual patient comes once a year to the big clinic. We do, it's a 2-day clinic in our space with split up into half days. It starts with audiology visits on the first morning. There's time and shared time in the patient family space, and then for play and talk and exchange while everybody's doing their visits. I always provide lunch. Afternoon on that first day is with a huge group, many of the specialists. And then the next day is for dental exams, eye exams, and then a visit with the otolaryngologist if the audiology study has shown that they need a visit there. So we try to get everybody their big visits on Thursday, and then if they need more time, usually they're done by noon, but if they need to stay for till that late afternoon on Friday, we do that. Try to do something fun like that, visit to the basketball team in that night in between. And we work to try with our Ronald McDonald House and local hotels to try to provide a place for folks to stay if they're coming from a long way. Our teenagers and young adult patients are all very willing to be patient advocates and to really do some sharing time with younger families. And that is really the design for our pediatric clinic. And as everybody here knows, we've had in caring for kids, you also meet the family members, aunts, uncles, parents, grandparents who have questions, who may also have OI and have questions about their own bone health. And so I built a team of adult specialists too, that any of those family members can get plugged in with. And Dr. Kleins is an expert in endocrinology, bone health, and so we start with him. So that's a really quick view of our team and another way to get all of those things done and really deliver really care that we're very proud of. So thank you.
Michelle, that was just great. And again, just a very different model. And I hope everyone appreciates the opportunities to share with you in just a few minutes. So last but not least, that's for sure, I'd like to introduce Sandesh Nagamani. Sandesh is the Vice Chair of Clinical Research in the Department of Molecular and Human Genetics at Baylor in Houston, Texas. Sandesh, thank you so much for joining us this afternoon.
Thank you, Dr. Tosi. And let me share my slides. I'm assuming y'all can see this now. Okay, perfect. So thanks for the opportunity to be able to join you all from Houston. Again, I'm just going to provide a brief update about the structure of how we have set up some of the skeletal and OI clinics at the Baylor College of Medicine in Houston, Texas. So this is the Texas Medical Center. It's, for those of you who've been down here, it's quite a large complex. It's the 9th biggest business district in the United States. So we have multiple institutions and multiple hospitals. And somewhere here where we have these 3 hospital buildings of Texas Children's is where the care for children with OI is done. This is where the pediatric skeletal dysplasia clinic actually is set up. So the SDC clinic is run out of molecular and human genetics. So we're lucky to have multiple faculty members who have a research and clinical focus on OI. I'm sure many of you or most of you know Brennan Lee, Carlos Bacino, Reed Sutton in the OI community. And we also have Dr. Lindsay Burridge, Ronit Marone, Karen McCall, and Chai Morley, all of them who provide care for individuals with OI and other rare bone disorders. We have a nurse practitioner who serves as a lead coordinator for the Brittle Bone Disorders Consortium for the research work, but she also takes care of the infusion and day-to-day management of multiple individuals with OI and other skeletal dysplasia. And we have a dedicated genetic counselor, Ahmad Gerard, who is involved in genetic counseling, ordering of the genetic test. The skeletal dysplasia clinic has been operational for many, many years and was established by Brendan Lee here. It is not a multidisciplinary clinic in that we don't have other specialty members come in regularly into the clinic. However, every month there is a skeletal dysplasia rounds, which are multidisciplinary rounds. We have individuals from orthopedics. Dr. Vinitha Shanava is the orthopedic surgeon who takes care of children with OI at Texas Children's Hospital. Matt Disler is the skeletal dysplasia radiological expert. He took over from Al Schlesinger when he retired. In addition to these, we do have clinic coordinators and other specialists at TCH who will coordinate the care. So for audiology, pulmonology, and others, they're within the Texas Children's Hospital environment for referrals. And the clinic leverages from the numerous diagnostic imaging and infusion facilities of TCH. And we also have many research coordinators who are involved in research studies who do approach patients in the clinic for longitudinal sort of studies so that when they come in for the clinic, it is time efficient for them to get both the visits over. Now, this is the adult practice, which is the Baylor McNair campus, which is around about half a mile away from the main campus. And I sort of serve as the physician for the clinic for metabolic and genetic disorders of bone that caters to patients with OI as well as other skeletal dysplasia. Alicia Turner, again, ends up coming over to see adult patients as well. We have two genetic counselors who act as clinic managers as well as point of contact for all the patients. And we have research coordinators and staff who help with the prescriptions and the infusion for the individuals. Again, we don't have a multidisciplinary clinic, but within the Baylor McNair campus, we do end up having all specialties. So if we do end up wanting them to have more than one visit at a time, we try to coordinate that on the same day. And we again leverage with the diagnostic facilities available at the Baylor St. Luke's Medical Center. One of the things what Dr. Tosi asked me to also present was what has been working and what has not been working. And since I'm going to have a couple of slides on that. So what I think we have been successful in doing is sort of to integrate clinical and research opportunities for patients. And our department serves as a center for many of the large networks. So for patients who have undiagnosed skeletal dysplasia or for patients who need clinical trials, there are opportunities that we can provide through what is available in the department. I think many of them find that to be attractive. And also we have a dedicated Center for Skeletal Medicine as well as the Rollnet and Burden Lawrence Bone Disease Program of Texas that sort of are involved in clinical translational research for bone disorders, which again increases the opportunities for the patients. Now I'm working on the adult side, and as Dr. Tosi pointed to in her talk, and as is well known to all of y'all, the care for adults is less centralized and coordinated as compared to children at most sites. And providers may have limited experience in management of OI, and these are some of the quotes that the patients have actually told me when they come to see me. One of them was that my doctor thought I did not have OI because I went into the office walking. Now, even though we live in a large medical center, I don't think knowledge about a rare disease is common. So these experiences are not unknown even within a referral center as well. Moreover, a challenge that I've had is that adult hospitals are not typically well equipped to perform procedures and surgeries in adults with OIM. This is a challenge that many of us face across, and I face here as well within the medical center. So what we try to do for coordination of care in the adults is I try to establish a care team and have patients and have a plan for their emergency care. I try to coordinate all their medical therapy. I have colleagues in pulmonology, in orthopedics, and ENT to whom I refer as required. If it does not require a referral to a pulmonology and I can manage them myself with the pulmonary function tests, I do not refer them. But if I do think this is beyond my payroll, I do have colleagues who think about this more deeply than I do. We also have other services that are required for patients with OI, but I have highlighted, I've underlined and marked them with an asterisk because the availability of a service does not, the existence of a service does not mean that it's available to all patients. And physical medicine and rehabilitation, especially PT, which is outside of our facility, given the logistics of insurance, is hard. Pain management is really, really hard. Many, given the opioid pandemic, and given most of the pain management clinics even here have transitioned to, epidural steroid injections and procedures, to have somebody manage their chronic pain is difficult. And this again comes back onto the primary caregiver. The thing that I struggle most with is how to provide dental care. We do not, even though it's a large medical center, the medical school per se does not have a dentist. And many of the dentists, orthodontists, have their own insurance related issues, and I find it really hard to have my patients get the appropriate dental or mental health care they need, again, because of the logistic issues of how these services are provided within our country. One of the things I always do is to make sure that I plug them to patient advocacy groups and family organizations, especially OIF, so that they are plugged in with these organizations to provide them with support. Another thing that I really find challenging is while I serve as the primary physician for their care to coordinate, some of these patients do come from the neighboring states, and given the compliance issues of practicing across state lines, it gets difficult to even call and put in orders or to coordinate care across state lines. And I don't have a bright idea of how this is going to be accomplished with artificial boundaries. But hopefully with Laura Tosi's democratization, this probably will end up getting better. So that's our clinic. And I just wanted to thank you for the opportunity, and I'll be happy to take questions with the rest of the team.
Very good. Thank you so much. All righty. Lots of ways to skin a cat, as we were saying. We really now just want to open up to your questions and discussions. We'll start by having folks put things on the chat, but I think we can also have people unmute when they would like to speak. We're eager to hear from you. I will tease you, Sandesh, and say, I think Kara has demonstrated her ability to change laws. I think she's the lady we need to get going. Telemedicine has been an extraordinary experience for me personally. I get to chat with my patients at length. It's very hard to do an orthopedic exam. But I think one of the big COVID questions is whether or not they'll extend our ability to do more telemedicine and potentially to reach cross state lines. Now, I know it's Friday afternoon, but don't just sit there.
I
Yeah,
do
Laura,
want to jump in. Oh,
Go.
Thanks, Kara.
I just
Yeah.
want to jump in. I meant to add a kudos that it's been bugging me that I didn't squeeze in there in my talk, but I did just want to commend and thank the OI Foundation and Dr. Sandhouse for those early days and I know it wasn't just you, Dr. Sandhouse, but particularly remembering your letters, you know, that I know that was difficult for just thinking about as a researcher. You don't want to make kind of predictions about the risk of COVID. And I saw a lot of other rare disease networks kind of decide to have a hands-off approach. But I really think that by kind of sounding the alarm early for our OI community and emphasizing how we could stay safe, I don't think it's over dramatic at all to say that it saved lives. And so I'm really thankful that our foundation and Dr. Sandhouse, with your expertise with explaining it so well through those webinars, you know, we were able to stay safe. So that was just my note that I didn't get to squeeze in there. So thanks.
Thank you.
Sandy, do you want to make a quick comment on how we're doing?
Well, I think that we've learned that the efforts that the patients and their families have taken have really helped to minimize the impact as much as possible of COVID in our population. We have unfortunately found that our predictions that adults who develop COVID who have OI might be at greater risk of winding up in the hospital or having more severe disease. And really our focus at this point is making sure that we answer any questions that OI families have that might lead to some vaccine hesitancy, so that we can get as many of our patients and their family vaccinated as we can.
We don't
Laura,
have.
Please, it's Michelle Caird. I wanted to say first, I put it in the chat earlier, but thank you to Kara for bringing up the advocacy work regarding patient support folks, because I personally had a patient who benefited from that, where we could differentiate between supporting people and visitors. And so great thanks to the group for the work that was done around that. And then I also wanted to add just a little bit to Sandesh. Thank you for your presentation. I think as an orthopedic surgeon, I think, one of the things that I've tried to do is find a partner who specializes in adult trauma, who has operating time and is facile with some of the more adult type fractures that folks have. But at the same time, I go and do the cases with him so that I can advise about bone quality and some of the other maybe tricks or tips that I've learned over the years dealing with the growing bones. And so I think that's been a nice model for us. And many of the specialists are pediatricians, but then just as many specialists have certification that spans the lifespan. And so even though as a pediatric orthopedic surgeon, I concentrate on kids, I am board certified to care for adults as well. And so I feel like that, I feel very fortunate in that certification to be able to, in the very least, advise and at most do the procedures myself in older folks. So I think that's one of the nice things about our clinic, in that I can be a bridge between the kids, the clinic for the kids, and then the care into adulthood too. And I think that having somebody that can that's passionate about it, that can help transition the kids, and then can really follow along into the adult realm has been helpful for us.
You are demonstrating and speaking to the real advantage of being at an academic hospital that does 0 to whatever. But there are so many freestanding pediatric hospitals, and we are truly challenged.
Yeah.
We have an interesting question from Jill Flanagan. So she's working hard to convince her hospital system to let her develop an OI multidisciplinary clinic. And any suggestions the speakers have who for her, and she asked, are there any published outcome studies demonstrating the improvement of outcomes with these types of clinics? And what about patient satisfaction? They must be very grateful for your 2-day event once a year. Thoughts on that? Helpful points for Jill.
Jill, we've been collecting patient outcomes from the start. So I just felt like we've got all these people together. We've got a focus on research. So it was a lot of patient satisfaction information that we collected along the way. And I thought that in order to keep this going, I was probably going to have to at some point prove that we had made a difference for people. And so we did some focus groups before we started to ask them what they would want. And then we're able to deliver on a lot of those things. So I think that's really key, to ask your patient population, what do you need right now? Where are the gaps? And then you can really robustly take it back to the hospital and say, look, we can fill these gaps in for you, and it doesn't take long, or whatever model you decide to use. But using the patient experience to help drive this is, I think the time is right for that, and our attention on that is really right where it should be.
Paul, Sandesh,
Yeah,
thoughts?
I think we're making transitions, because I know Frank Rausch and his group showed a lot of functional improvements. And now I think the next phase of that is to show patient satisfaction and changes. And the one thing I know Jill is doing a great job of there is taking those same resources, and the hospital loves when you generate more numbers, and you can take those same resources, as Megan is doing here, where that's now becoming a bone dysplasia clinic, which is now becoming a dysplasia clinic. And you get a lot of people excited about it. So I think that's what you do, is generate numbers, because that's what hospitals do. And now that I'm an administrator, I know that.
Great. Sandesh, thoughts?
I don't think I have anything more to add than what both Dr. Caird and Esposito have expressed. But one of the challenges that I've found in establishing a multidisciplinary clinic is that it's hard to get all specialties equally excited about a disorder which is not their primary passion. And so, when as an administrators, again, what they would look at is the amount of physician time that is spent versus a number of patients who come in. If we do have critical number of patients that will be seen in multiple different, not within the same clinic space, because from what I understand, it may be a billing issue. But if it's within the suitable clinic spaces, then I do think that we'll be able to pull it off. We need to have a critical number of patients and to engage the right sort of people.
And
thank you.
I agree, Sandesh. And the other thing, really going through and knowing the people that you're inviting to be part of that clinic, and knowing what they need out of it. So I went to each person and said, okay, your track is clinical here at the medical center. What do you need? How can I help because you're helping us and you're helping these patients, what do you need out of this? And so people on that instructional track really needed talks nationally and papers, and so we worked on that for those folks. Other people needed grants, and we worked to get small grants for people. And then for one of my partner in endocrinology, I was able to recommend her for a leadership program because I was so familiar with her great work. So really getting to know on an individual basis what those people need to get out of it and making it very personal to start with was a good tactic for us.
Yeah, thank you for those comments. Those are helpful. I would say Atlanta, luckily we're blessed with a lot of volume, and I already have the people identified. The challenge in Atlanta, for those who know it or are confused by it, the city's huge and there's 2 hospitals, and everything is all over the place. Where I am versus my endocrinologist are 2 different hospitals, even though we're the same system. And so these families are traveling hours away and they're going all over the place, and traffic is getting worse again. So that's what's really driven it, is we want to be able to provide this excellent care, but the families will say, oh, I already done endo and I've done ortho. I don't want to get my audiology done. I'm done. I don't want to get my dentist done. So that's where we're challenged. And so luckily, I think administration hears it, and I showed it to them, but I think I'm on the cusp. But again, I figured, are there buzzwords I need to tell them? Again, patient outcomes, patient satisfaction, I think they're looking for that. And if I could have shown that the outcomes are better, they might listen more, obviously, but we know that the outcomes are better. I just have to prove it.
So Michelle just had a great comment, which was virtual. And I think you'll appreciate that COVID's been very hard because they literally won't, they've kept the number of patients down in the clinic, and we can't, for a long time, we couldn't have medical students and whatnot. And so what we did actually was, for my bone health clinic, we brought in endo virtually. And my iPad is now, looks like a spider web. I've dropped it so many times, but that's how endo comes to the appointment. And I'm hoping you may be able to leverage that as an idea too, because I hear you on travel. That does us in at every turn.